Chair, we've had apologies from Councillor Kelly Martin and Councillor Farhad Chubadars here as his substitute.
Thanks.
Thank you very much, and I hope members have a copy of what I'm going to cover in front of them. And my apologies, because we've just been finalising the year-end position and I wanted to give the most up-to-date position. It is a summary document, and the reason for that is that I think I gave a pretty comprehensive update when I was here in January, which gave the first 3 quarters of the year, and therefore what you have here is really just tying up the year end with some highlights, but I'm very happy to take questions. So if you go to slide 2 in the presentation deck, the first thing to remind everyone about is that the Trust, as part of its 2022 to 26 strategy, has 6 strategic priorities covering quality, people, performance, finance, strategic programmes and partnerships. And you'll see in that we have a set of words around what we aspire to achieve this year. So if I use quality just as one example, we wanted to provide high quality care that strives to achieve a good overall with no criteria being assessed as inadequate against the CQC criteria, and I'll come back to that in a moment. So it's just to give you an idea of those were our broad aspirations for the year, and then we had a series of specific indicators against each of those aspirations, and I presented this information at the last committee meeting. If you go to slide 3, what you have here is an overall position for the end of the 22-23 financial year, and although it talks about the last quarter, it's actually giving you an outline of where we got for the year as a whole. So what you see on the charts on the right hand side are, and we assess in these presentations, we assess green as having been completed, amber as being that we still had some things to do but things were broadly delivered, and a red would mean we hadn't delivered it. And where we've got an amber green, it's heading for green. And apologies, because I think you've got black and white copies so you can't actually tell. No. Yeah. So none of them are red. So, and what we do is we report each quarter on the business plan delivery. So you'll see that some quarters were amber and then turned to green towards the year end. Some were green. So if I take partnerships, we assessed ourselves as green for quarter 1, amber for quarter 2, green for quarter 3, but amber for quarter 4. And again, I'll give you a little bit more information on that. So I think the thing to say broadly is that actually our focus during last year was particularly on making sure that we managed our finances carefully, that we delivered high-level performance against the national standards that were set in the NHS, that we had a focus on the people that we employ and the people we serve, that we absolutely didn't lose sight on quality. And quality, we had green, amber, 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 but I'll explain why quarter 4 was amber. And generally, I think we were able to demonstrate in previous meetings that particularly around partnerships and strategic programmes, we've had some really good success on that. So the things that I want to pull out from the text really are to say that in terms of quality, actually you will, in the local authority, a number of you will see our quality account that has in great detail what we delivered in terms of quality for this year, and that's a separate document to this one, which we always get feedback from the local authority on. Where we did well was on a number of our key indicators like falls, pressure ulcers, infection rates. However, unfortunately, we were inspected by the Care Quality Commission in August of 23. They reported on the 14th of February 2024, and unfortunately our grading for maternity services moved from good overall to requires improvement overall, and that was very disappointing for the organisation. And we have a programme of action in response to that visit, which is now underway, and we are taking very seriously about how we work with our local community to make sure that we move that back to good and outstanding overall.
One of my questions was going to be, why did that happen, and what have we done, and what are we doing about it? So, if it's okay, do you want to answer that at the end of your presentation, or would you like to take that now?
Can I do it at the end of the presentation, then I'll come back to that? Yes, very happy to answer that. In terms of people, we saw improvement across the board, and actually, although it's not said in here, actually our staff survey was an improvement on previous years. So we had an 8% increase in response rate. All of our key areas moved upwards, which was very positive in the NHS, and particularly those areas where we had put specific effort. So our staff engagement score increased, our team working increased, working with my manager increased. So some really positive things about changing the culture in the organisation. I should say that overall in the NHS, the staff scores are not where we would like them to be. They're sort of 6 to 7 on the ratings, and as an NHS we should be looking to improve our staff scores to a much better level. But given how much has been going on in the NHS, it felt like we turned the corner and we're heading on an upward curve rather than a downward curve. So that's very important for us. Performance, I've got a few more detailed slides, so I'll come on to that. We had great success in performance and moved ourselves back to the level of performance we had before the COVID pandemic, and exceeding activity and performance in that area. With our financial plan, we put that as amber because we had a very stretching financial plan for last year. We did actually end the year at a balanced position, although we declared a deficit, and that was because of a technical issue around the new hospitals programme and some of our decant and enabling work. But that was sorted out across the acute provider collaborative. And isn't something that adds to our underlying position. So that was positive, and we made some positive moves on our underlying financial position. In terms of strategic programmes, a great deal to be celebrated around the fact that we implemented a new patient record system called Cerner. And in fact we did that, I'm seeing some nods beside me, but actually we handled that programme rollout incredibly effectively. We did it immediately after the rollout at London North West and used the same team, so we learned from what happened at London North West. And the big success with that is that all 4 acute trusts in North West London have the same electronic patient record system, which means that if you are treated as a patient at Hillingdon but you had care at Imperial or London North West or Chelsea, we're able to see your previous records and can make sure that you get joined up coordinated care. So it means that our medical and nursing staff actually are able to access records much, much more easily. And I think that's worked very well. Clearly our other strategic programme was the new hospitals programme. Lots of successes there in terms of getting full planning permission during the year, and knowing that we're ready to go. I think some of you will be aware that the new hospitals programme has been slightly delayed. It's just about going through the governance and making sure that such a huge programme nationally is following due process, and we hope that we will hear soon that we've got the next tranche of funding to go ahead with that, so that's positive. And then the final thing is around partnerships, and I think you're aware we are in a very strong partnership with the Hillingdon Healthcare Partners, and you heard from Keith at the last meeting about how that work is progressing, and that it feels a very positive relationship, a much stronger relationship with the local authority, with CNWL, actually all of our partners. So that for us is a very positive piece. Because we've improved our performance, we're able to demonstrate that as an organisation in our own right, we're credible and sustainable. And we are now, or have been since 2022, in the Acute Provider Collaborative with ourselves and the other 3 acute trusts in North West London. And that work is really starting to move at pace. We had a development day yesterday where we were looking at our strategy, and that's something that I could bring back to a future meeting around what are the things that we believe we could do in collaboration as a 4. And we've got a philosophy which is, what would you only do once as 4 organisations working together? What might you do with partners in key things? And then what are the things we absolutely do as an individual standalone organisation, because we are still a statutory organisation in our own right. So in summary, I think a very positive year, but absolutely not resting on our laurels, a great deal more to do. If I can just move you to the next slide. This is really around our operational performance. And it should say A&E, it's just got slightly missed off. But urgent and emergency care absolutely has been a concern for our local population about waits to be seen in our urgent treatment centre and in our A&E department. The national target for the month of March was to hit 76% of patients being seen within 4 hours. We achieved 78.5%, and if you look at some of the charts we presented at a previous meeting, that was actually a significant increase on where we'd been before. We've sustained that improvement through April. It's dropped a little bit in May. We are very busy in the urgent and emergency care pathway. I think the ambulance service will say the same. But we absolutely have a plan that we believe we can now stick to and deliver, which is good. And I can say that the number of complaints that were high during the winter months have dropped off tremendously. And I think when I was here in January, there was real concerns about, your local population complaining about the lengths of waits and the experience, and that has improved enormously. Cancer has been a concern for us. The FDS is the faster diagnostic standard, and that's, do we do the diagnostic tests quickly so that people who may have cancer get a diagnosis quickly. And we met the standard and have continued to improve on that standard since February onwards. So that is really positive. We're getting people tested, seeing them more quickly, and our cancer performance is improving alongside that. Elective activity is where we've had huge success. So just to give you a summary on what's in the bottom right-hand corner, we had nobody waiting 104 weeks in 23-24. We achieved our 78-week target during the year. By the end of March 31st, we only had 2 patients who'd exceeded 65 weeks. Now, none of us should be proud of patients waiting more than 12 months to be seen, but you have to remember that actually our average waits are much shorter than that, but we have a long tail. But we've very specifically focused in North West London on getting that tail of patients who are waiting a long time down. We more than halved our 52-week plus waiters, so we're in a good trajectory to get people down back to where we should be, which is an 18-week target. So given that across the country many systems are struggling to reduce waits for patients, it's a very, very positive story across North West London and with the Trust. And one of the things that's helping with that is our theatre productivity. So we are always in the top decile in terms of theatre productivity. So that's a measure of how well we're using our facilities and how well we're using the capacity that we have available to us. And then just to finish, you asked a bit about what our ambitions for this year. So this is predominantly focused on operational performance, but our ambition for this year is that no patient should wait longer. 80% of patients should be seen within 4 hours. We've done a lot of work with LAS around reducing the 30-minute wait for handover, and that has improved enormously again. Frailty assessment is a really important thing, and actually our frailty assessment service is an exemplar across London. We want 25% of patients who present to the front door of the hospital to be seen by the frailty team and hopefully dealt with and sent back to their place of care, be it their home or in a care home, very quickly, because we know that older people who end up in hospital deteriorate very quickly when they're in hospital. So it's to try and get them staying well at home. And we have a process called criteria-led discharge, where there are certain criteria people have to meet, and then we will get them discharged back to home. And actually, working very closely with the local authority, we have one of the lowest numbers of patients who are waiting for discharge inappropriately in hospital, and a huge thanks to the local authority, because we've worked very effectively with you on that, and it makes a big difference to patients so that they don't need to stay in hospital longer than they absolutely need to. I'm not going to go through all of the targets that are on here, but I hope what you'll see is that we are absolutely on an improvement trajectory on most of our elective targets. We're increasingly focusing on equity of care. So we're starting to do a lot of work around what do we know about our local population, what do we know about the ethnicity and the cultural differences of our local population, and what that means in terms of how quickly they're seen, whether they don't come for appointments. And then the plan is that during this year we will actually target those populations, get better at communicating with people who don't come for the appointments, make sure that we're not in any way giving one group of the population more access to care than others. So I think that's a really positive move, and again is something we're doing across North West London. In terms of working with HHCP, absolutely, we're focused on reducing demand at the front door and how we reduce length of stay so that patients stay for the minimum amount of time they need in the acute hospital. And somebody made a comment the other day about does the hospital just become a conveyor belt? And that's not what it's about. It's about, can we provide acute care to those people who need it, rather than just have a slow conveyor belt that people move through the hospital. So it's, care should be in the most appropriate environment, and that's very much the work we're doing with HHCP. Under digital, we've got a couple of things that we're doing. So we have a thing called the Federated Data Platform, which is a national digital tool, which is a way of managing the patient care pathway. And that's actually a really exciting development, in that you might assume that with our electronic patient record, we have a way of managing a patient's pathway. But the electronic patient record is the record of the care you have. It's not a record of, it's not a pathway management system. So it's not a system that says you came into, you were referred by your GP, you were then seen in outpatients, you then had a series of tests, you then might need surgery, you were then admitted for your surgery, and then what did we do with you in terms of your follow-up appointments? And the Federated Data Platform is a really neat system that links up all those steps and allows us to check that you're not going to breach 65 weeks because you didn't have your diagnostic test, or that we're not following up on your care pathway. So that's something that's being rolled out nationally, but within North West London we've been a pilot system for that. So it's starting to prove really helpful in terms of the way we manage our waiting lists, how we prioritise patient care. And alongside that, during June, we're going to roll out a system called Doctor Doctor, which is used in some other trusts in North West London. And it's a technological solution that allows us to communicate with patients much better than we do at the moment. And, I've heard from this committee and others about patients who are phoning the hospital, they don't get an answer on the phone, they get a letter that says, your appointment's been cancelled on the day that their appointment occurred. And Doctor Doctor, we know from evidence elsewhere, is a much, much better way of managing patient care. And then the final thing is the exciting bit, which is continuing our decant programme. So you'll be aware that as part of the preparation for the new hospital build, we have to clear about half of the Hillingdon site. We've had a policy of moving. The majority of the things we've moved to Mount Vernon have been our back office and administrative functions, with a few bits of clinical service where it makes sense to do that. I mean, we are serving the whole population, whether you're seen at Mount Vernon or you're seen at Hillingdon, and we have our elective centre up at the Mount Vernon site. But we have a very concerted piece of work that we will be doing in 24-25 about moving wards into the main block. If you've been on the Hillingdon site recently and in the annex corridor, you'll see signs that say this ward is closed for demolition, and that's because we are closing off areas with a view that during 24-25 there will be bulldozers in knocking down some of those old areas. So it's quite a tricky jigsaw puzzle at the moment about moving things into different areas and working out have we got enough space, because the estate is tight at Hillingdon in order to make everything that we feel needs to be on the acute site there until we've got the new hospital build, but that is moving very positively. So that's what I wanted to highlight.
Thank you. That's very useful.
So those of you that may have taken an opportunity to look at the CQC report, there were a lot of very positive messages about the service, and I should point out that they looked specifically at the safe and well-led domains in the CQC, and the focus very much in the context of a number of national reports that have been in the press for the last few years about maternity services in general. The CQC have had a programme of inspections over the last 2 years where they have inspected every maternity service that hadn't been inspected, I think, since 2018. So we knew we were going to get an inspection. We did a lot of work in preparation for the inspection, and actually on the day that they visited, they were very pleased with what they saw. However, the maternity, I think it would be fair to say that in maternity services nationally, a number of things have changed since the Donna Ockenden report was published on maternity services, in as much as we've seen a change in the acuity of women who are giving birth. So there was a time when having a baby was a normal process. You weren't unwell, you had your care, you came into hospital, you had your baby and you went home. But actually many more of the people who are coming for care with us have quite complex healthcare needs, and that means that you need much more intensive input right along that maternity pathway. And what the CQC noted was that there were some of the areas in our pathways where we were perhaps not as sensitive to our local population as we should be. So things like maternity triage, they felt that we should be reviewing that process. So if you're due to go into labour and you're concerned that your contractions are starting, or your waters may have broken or whatever, then we have a triage system that says either you don't need to worry about it, stay at home. When you get to this stage, then come into hospital or come into the triage service. And they noted that actually our triage service was not as well resourced as it should be. It's something that we were aware of and trying to correct, but they were concerned about that and concerned about making sure that that whole pathway was as smooth as possible. They had some concerns about the training of our staff, so a few areas where they felt staff should have been more up to date with their training, and that wasn't acceptable. It was an entirely appropriate assessment of where we were. And a number of areas where they felt that some of our processes and procedures we could be managing in a tighter fashion in order to make sure that care wasn't compromised in any way. So, I mean, that's just a summary of where we got to. What we have done since then, so there's two things for the committee to be aware of. So we had already started working on this. So there have been a number of programmes that we've had underway since the Ockenden review. So we've had an Ockenden action plan. We have a number of indicators of care that we monitor on a regular basis, and they go to our Quality and Safety Committee. And we work very closely with partners across North West London. And we had brought some external people in the autumn of last year to say, actually, will you have a look at some of our governance and some of our processes and tell us where we can improve that? So that work was already underway. We've pulled those pieces of work into what we're calling our maternity improvement programme. That work was already underway before we got the CQC report. So we're running that alongside the responses we have to give to the CQC about where we are. We've answered or addressed about 50% of things that were in the CQC report already. And the second piece is that at a national level, all trusts who are either requires improvement or inadequate in the CQC assessment have the option to go into what's known as the MSSP programme, so it's the Maternity Safety Programme. So we've said we wanted to be part of that programme because we get access to quite a lot of national resource, and it gives us a comparison with the rest of the country and learning from the rest of the country. And we've just gone into that programme, and we have a national team who are now working with us. So and the approach we're taking is this is for us now to turn this into a positive story about how do we learn more from our local population. We've got an absolutely fantastic Maternity Voices partnership. They're doing some really, really good community work. We want to support them more so we can learn more from our local population about what they want from their maternity services, and then making sure alongside that we're putting everything in place that should be there to make sure that every woman has or birthing person has a safe journey through their maternity pathway. So we're absolutely not complacent about it. We didn't want to be where we are, but we've taken it very seriously and are absolutely determined and committed to being an outstanding service for the population of Hillingdon.
I think it's very positive, obviously, that we're going into the national programme to get as much help as we can. And obviously, this is an opportunity to improve, and that is great. But if I was about to have a child and I came to you and I said, I'm actually really worried about going into Hillingdon Hospital. I see you need to require improvement. I've seen in the news over the last couple of years there's been some really scandalous stories about maternity. I am actually quite worried that I'm going to be giving birth in Hillingdon Hospital. What would you say to me?
So we have about 4,000 births per annum, and the majority of women who are cared by us are cared for very well and would report that that's the case. So, we have a safe service, we have a service that we are monitoring all the time and making sure we learn from lessons. And I think the area that we probably are focusing on particularly is making sure that every person's experience is as good as it can be. So that's the bit that we are really working on at the moment. So nobody in Hillingdon should lack confidence about coming and having their care with us. And we would want people, when they're with us, to say, this is what I'm worried about. I've had this experience before. Please listen to me because this is the experience we've had before. But what they should be confident about is that we are absolutely learning and making sure it's better for everybody for the future.
Thank you. Rita.
Sorry, Chair, I thought if it was on maternity, you can carry on. Thank you, Patricia. I've had 4 kids at Hillingdon Hospital, so I'm just a bit surprised that we are where we are because I've had 4 wonderful experiences. So it's disappointing, but we're trusting you to put it right. And so we expect an update soon. I've got a question around A&E. We've said that you've still got challenges. Whilst we've hit 78%, is the trend still there where individuals can't get a GP appointment and are just walking into A&E? Is that still there?
Thank you. Not always because they can't get a GP appointment. There are some people who will come to A&E, as somebody once described to me, because they come where the lights are on. And, you can't see a GP mostly at midnight or 3 o'clock in the morning, and if you're waking up and you feel very unwell, you would come to the emergency department. What we do find is that we've got huge peaks and troughs in attendances. So we would reckon, on average, we would see about 350 people through the UTC and the A&E department in a day. We've had a number of days recently where we've seen 500 people in the day. So it's the thing that's very difficult to manage is that massive variability. And I couldn't say that that's because people can't get a GP appointment. It's for all sorts of different reasons. We are, if you remember, the receiving hospital for Heathrow. So you do quite often see people trundling around the hospital with their suitcases because they've been unwell on an aeroplane or at Heathrow and they come to us. So it's not just the local population who come to us. But if Keith were here, he would say actually there's been some really good work done recently through HHCP about creating the GP hubs, and we do believe that where the two hubs that are open at the moment are starting to be in a position where less people would come to us because they can't get a GP appointment, and I think we'll see an improvement over that over time. But I don't think we'll ever stop people, unless we say you can't walk into an emergency department. We'll not stop people coming if they think they'll be seen more quickly.
Cool. June.
Thank you, Chairman. Patricia, I'm a bit disappointed to hear, because when we had when you gave us the brief before was so positive, especially for the maternity unit. So I'm disappointed to see that this massive big cloud come over in regards to maternity unit lacking in certain aspects. Is this to do with a language barrier that people don't feel confident? Is it to do with the growth of our diverse community that's coming in, that's having this effect? Because where we used to hear quite a lot about women's experience going into hospital to have a baby and some of the challenges that they face, is this still happening? Because really it's some cause for concern to think that probably this is along the same line in regard to the QCC not meeting that standard, even though we had a lovely update about the maternity side of things, how it has moved forward, especially with the Ealing Hospital side coming over onto the Hillingdon side. So can you update us now on where you're at with that, because it's cause for concern?
So I'll take it in 2 points. So you're quite right. When the Ealing unit closed and work came to Hillingdon, I think at that time, and actually still, the service that we provide in terms of maternity care at Hillingdon is very good. I think there's two things. The first thing is that the standards of care and the level of scrutiny on maternity services since the Donna Ockenden report is much, much higher than it was before. And there isn't a unit in the country, there are very few units that haven't had a change in grading. That doesn't make it good, but it does mean that's a much, much higher level of scrutiny. And that's a fair challenge to us all. That scrutiny should be across the board, actually. In terms of the language barriers and the ethnicity of our population, so we have identified that there are more women where, women or birthing people who are who have English not as their first language, and that there is definitely more we should be doing around making sure we are absolutely clear about how they wish to be communicated with, what support they need, and actually particularly their understanding of the pathway of care, particularly if they haven't had a baby before. And that's a piece of work we already had underway about improving our translation services, using Language Line more. But what we've also put in place now is longer appointment times at the beginning of the maternity pathway, so that we make sure we give women where English might not be their first language the opportunity to have a longer discussion. To be honest, actually it's not a bad thing for all women, because if it's your first baby you're probably anxious about lots of things, and therefore that, how do we do that initial risk assessment as rigorously as we can to make sure that we don't miss anything. What we can also see, and there is now more evidence that there wasn't previously, is the difference in outcomes for women from a BAME background, and that's part of the work we're doing around equity to make sure that we're not missing anything from that population. So it's, I agree with you, it's disappointing, but it's not. It's a journey about making sure we understand what the issues are and making sure that we're now taking action to resolve the learning we've got, and making sure that we're continually monitoring that. And I can absolutely give you assurance that that's where we are.
Thank you for that. Thank you for that, but I still think that there will still be concerns in regards to that, because what you're saying to me and what you're saying to us here today does have an impact, because our community do have very grave concerns in regards to attending maternity unit and the way that they feel that they're not being listened to and how they're being treated. So just to let you know, it is still out there in the community. The other thing is, Chair, one more question, on the A&E attendance at A&E and that long waiting list. And as Rita said, is it to do with the GP service? It obviously has something to do with the GP service, because we don't have enough GP service in the borough to accommodate the large amount of a community, because we're expanding so much. I was hoping that, is it Richard? Was here, so he can answer some questions in regards to that. But obviously he's not here, so I'll hold it back for when he's here the next time. Any improvement on that? Because if you're having that amount of A&E attendance and our residents going into A&E, I know you said that the waiting time is coming down. It's from 76 instead of 75, which is a national limit, so you just about just 1% over. They wouldn't feel very comfortable to know that it is still ongoing, even though you're stating that a massive improvement. But listening to the figures, it's not a massive improvement. It's still something that is cause for concern in our community.
So I can't answer the question about general practice, because I'm not close enough to whether or not we have enough GPs locally. What I do know is that we are working very closely with Hillingdon Healthcare Partners to make sure that we've got in that partnership the processes and the facilities to make sure that patients are seen in the most appropriate environment as quickly as they need to be, and that is the development of the GP hubs. So the GP hubs are not just about being seen by your GP, but you can also get more rapid treatment in the hub. And I think as that develops, I've seen that process elsewhere, and actually it does create greater capacity. And in terms of the ED performance, so the national standard for emergency access was that 98% of patients were seen within 4 hours and then moved on to another appropriate environment, so either discharged. We haven't achieved that in the NHS for quite some time. The national standard now is that for this coming year is that 78% of patients should be seen within 4 hours. And you're quite right, the 22% who are not seen within 4 hours are not going to be happy about that. Now, some of those, and this is an important point, some of those may not be suitable to be moved on from ED in that time. If you've had a major car accident and you need to be stabilised in ED and the trauma team are with you and it takes you 6 hours to stabilise you, we're not going to move you somewhere else if that's the most appropriate environment. But we are absolutely determined that wherever we can, we will improve the length of time people stay in the emergency department. And for some people that might be a 6 hour wait, but for some people it might be 4 hours and 10 minutes. So it's not just about hitting the percentage, it's also about what that means in terms of time. So all I can say is that we are absolutely focused on how we make sure that we make people's experience as good as it can be and as rapid as it can be when they come through the department. Can I just say one more thing about maternity services? And actually, you make a really helpful point. So one of the things we are doing with our plan is to say, actually, what do we need to make sure that people's experience of maternity care is as good as it can be? And you will see in this next year a very concerted effort of us getting out into the community, working much more closely with women who've had babies, women who are due to have babies, women who might be, in that group of people who would be having babies, to really learn what else we need to do in order to make their experience better and to make it much more tailored to individual needs. So it's not we haven't been doing that, but what you will see is a very concerted effort to get that right, So I wouldn't want you to go away from today saying, 'twas ever thus, and is it ever going to change? Because that isn't going to be the case.
Thank you. Philip.
Thank you. I won't say anything about maternity other than the fact I've been in the delivery ward on 4 occasions in the last 30 years. But I'm afraid I'm going to start with a bit of a moan, unfortunately, because it relates to information we've been given. So we've had the quality accounts. We looked about 2 weeks ago. So I'm looking through those. They've helped frame my line of questioning, really. Although we've had this evening, I know there's been a bit of catch-up to do, and you've had a bit to get ready. I do understand that. I'd respectfully say and suggest that we could really do with it a little bit earlier. I'll say that to any partner, actually, not just at the hospital. So can I just make that point and leave it there? I do have 2 or 3 questions, if you'll indulge me, Chairman.
Depends how quick they are. Definitely 2. If they're decent time frame, then 3.
I'll try and keep them short. Okay. So I'm just interested in engagement with groups like Healthwatch and obviously the patient partnership group, the sort of input they have in, oversight they have into the sort of stuff you're presenting, what sort of feedback you've had, and perhaps an example of how stakeholder engagement that you've undertaken to do your work has perhaps made a practical difference to any particular service. Perhaps 1 or 2 examples that you could maybe give us to illustrate that.
So we work very closely with Healthwatch, and in fact we've been meeting recently about the fact that with Healthwatch have a number of duties, so Healthwatch can come in and inspect, and I've said we would welcome that. It's not been something you've particularly done with the Trust, and Lisa and Lynn and I have been talking about this, but actually I would welcome Healthwatch coming in and doing inspections of what we do. They have a statutory right to do that, and I think that's a very positive thing, and we've been talking about some of the areas we might want to do some work on that, things like experience in the emergency department, and I think that would be very helpful. We use our patient experience group to do things like check some of our patient leaflets and those sorts of things. We have our governors and some of our patient experience group do walk around the hospital and look at patient food, at cleaning and those sorts of things. And again, we've had some very good feedback from them around that. Do we do enough? No. I think there's much more we can do about how we engage with our local population. So we use things like incidents and complaints, learning about what the public are telling us about our services. We follow up on all of those issues. We make improvements for that. And we also use compliments as well to say, that's gone really well, we've seen a change, we've made a change and it's made a difference. But I think there is more we could do around what we call co-production around services, so that when we're looking to improve services, that we use working with patient groups to help us do more of that. The area where I think we're probably slightly lacking, in fact we've been talking about it recently, is how we get the younger voice. So we do have our Maternity Voices partnership, but clearly they're very young voices if we're getting the voice. That's the mums, if you like, but we don't have particularly young members on our patient engagement group, and we would like to see some more of that.
Thank you. A couple of quick ones, if I may, then, relating to the quality accounts, having looked through them. A couple of things struck me from the quality accounts. So on page 61, there's reference to the emergency readmissions to hospital within 28 days. This was one of the old BCF measures, as I recall. One of the things we looked at in some detail. Not a huge amount of detail there. I couldn't see a target or any geographical context relating to it for perhaps comparator authorities. So just anything you can say about that is my first question. And I'll quickly...
Just take one each one at a time. I think that's easier for the person answering.
So I don't have the quality account. I don't have the quality account in front of me, so I don't know if I can answer your specifics. So what I'm not clear about, so we do have 2 measures that we look at: emergency admissions to hospital within 31 days, and we have emergency reattendances to the ED department. And I think you're talking about emergency readmissions to hospital. Now, I can't that we do have a standard for that. It's in our integrated quality and performance report, so we do have a measure against that, and our emergency readmissions from memory are where we would expect them to be, but I can't honestly remember what that target is off the top of my head.
Well, thank you.
And we have the opportunity still to modify our quality account, so I'll make a point of that.
Yeah, I mean, I suppose it comes back to the information we're getting to help us undertake our statutory role. One other question, if I may then. Patient experience of hospital, page 70, is referencing quality accounts. There are no figures from 21-22 onwards for some reason. If I've read it correctly, if you can't answer that question, could you let us know about it,
yeah,
please?
so this is page 70.
Page 70 of the quality accounts.
We do have a copy here if you want to.
Is it in the...
If you wish.
No, it's not.
Unless you want to report back.
Well, in Nikki's bag, Nikki's prepared with everything you see, so.
So page 61 is readmissions. So DNA is data not available, and I don't know the answer to that. I will have to find out why not. I suspect that just at the point of issuing this, but I don't know why we haven't got 21-22, because I'm sure that was in last year's. I apologize, I don't know. I'll have to check that for you.
Okay, so Nikki can take both those points.
I'll leave it at that. I won't push my luck any further. Thank you very much.
So yeah, so Nikki can take both those points and ask them sort of officially as well. So thanks, Philip. Situl.
Thank you, Chair. Patricia, thank you so much. I know you've been absolutely, bombarded with questions. I've got a question in a statement, and I've got two topics, but I just want to go to the first one, if I may, please. Something that I found quite interesting about what you were saying was complex health issues. And I think that probably is a thread that runs through most of the hospital probably now. And that then linked with the demographics of our population coming in and talking about understanding the needs of the new demographics, which could be stuff like lifestyle, diet, other things that contribute, and also race-specific illnesses or ill health that are particularly prevalent, like, for example, diabetes in particular communities or heart disease in other communities and things like this. So I kind of feel that could be something that could be woven through most of the services there, which then takes me to the fact that in everything that you've said through these reports, that there could be the fact that what Hillingdon Hospital used to deliver as a service needs to almost adapt and change to the changing demographics of the borough. Then that takes me back on to back into maternity. Excuse me for going back into maternity, but it just seems to be what we've got here. Is that when something moves into a certain space and you've got complex health issues, what I've noticed in all kind of reading about things happening in other places, in other trusts as well, is that the amount of agency staff or the retention of staff, because we've talked about this previously in this meeting with your staff retention surveys, and that there is an issue with replacing staff and then keeping staff on. So I just would like to ask a question around the agency staff that could be potentially used, which therefore may not be trained to the criteria that Hillingdon Hospital has, because they come in and come out. Having personal experience of something like that, having my first child, I will say that it was a very traumatic experience. And if other people have to go through that where English isn't their first language and they have complex health issues, how does that get dealt with? And is that a contributing factor to the maternity service?
So we have strict rules about agency staff in that they have to go through accredited agencies and they have to have done appropriate training. We have this last year very much focused on how we recruit to our bank, because the bank tends to be people who work for us regularly but want extra shifts. So we've increased our bank staff considerably so that we use more bank if we possibly can. You will see if you look at some of our data that we've had quite a high agency use in this last year, but that was predominantly down to two things. One, covering industrial action, and secondly, the fact that we introduced a new electronic patient record system and we specifically rostered staff to training, so we brought in bank or agency staff to cover those shifts, so that had quite an impact on that. In terms of, within our maternity service, I think it's well known around the country that there is a national shortage of midwives, and we have a high vacancy rate. We have funding for all the midwives we need. We have national standards that we have to meet in terms of what's known as birth rate plus, so the number of staff you have to have on duty. Although we don't necessarily have the number of whole-time equivalents of permanent staff, we do fill to birth rate plus on our shifts, and where we can we fill with our current staff doing extra shifts, and then we do use agency where we have nowhere else to go. We would never put no, I'm not going to use the word never because that might not be true, but we would endeavour to not have any shift where an area within any of our clinical areas actually was completely staffed by agency staff. We would always mix them with our regular staff so that they were supervised by staff who were familiar with the systems in the trust. And then the other thing to say is that we have a very active, so a couple of things we've done over the last few years. We have a very active recruitment process. So we have recruited 20 international midwives. 8 of them are starting this month. We've already had one start, and the rest will follow in due course. They come very well qualified. We give them a very good induction programme, and they are supernumerary for a period of time until they're familiar with the way we work in the UK. The other things that we've done is that we've looked at duties within the maternity unit that could be done by someone other than a midwife, as part actually of staff development, but also about making sure that we maximise the amount of time our midwives have to care for the people who are giving birth. So in our maternity theatres we now have theatre nurses instead of midwives, and they are well trained because they're used to handling theatres, and that means the midwife can have specific focus on the person giving birth. But if you like, the recovery care or the support to the anaesthetist or the obstetrician in theatres is carried out by a theatre nurse. So that's freed up midwife time. And we've done a lot of work and actually want to do more on maternity support workers, because actually what we know is that after a woman has given birth, actually a really well-trained maternity support worker can help with breastfeeding, can help with the care of the baby. We have paediatric nurses who look after the babies. So we try to think very creatively about what is the mix of care. And actually we do have some nurses now on our antenatal ward where the woman may need care of a caesarean wound or whatever. They don't need specific midwife care, so the care can be shared with other professionals. So we're trying to think as creatively as possible about maximising the spread of a scarce resource, so that it's focused on the things that a midwife is absolutely trained to do.
Thank you. I would like to offer another creative solution, if I may, and then ask a follow-up question. The NCT was quite critical in, helping new mums with the opportunity to kind of the pre-birth journey and then the post-birth journey, actually, and enabling that birth journey to be really, planned as well for new mums. However, it is very middle-class activity, and it is not something that reaches out into all communities. So I wonder if there is opportunities for that kind of partnership where that could be extended out into communities where English isn't their first language, and into our diverse communities around the borough. And on top of that, I would like to ask a question about what is Doctor Doctor? Is it an app? Is it and how does it then, when you've got things like a diverse group where maybe English isn't their first language, or they may not be digitally able. How is that going to help those patients, because they're the ones with the complex health issues?
Your first question about NCT in inverted commas, how can we do something that's like that but different to it? That's exactly the work we want to do. Is how do we create those communities that we engage with and talk about, so what would we do different with your group? What are the things we need to do? What are the communication materials, communication methods that we should be using? So that's absolutely what we want to do. And helpful, thank you to endorse that. I wish you hadn't asked me about Doctor Doctor. So I do know what Doctor Doctor is, but actually the detail of it, I can't tell you immediately. We're in the process of rolling it out. I think that it is adaptable and can be used with different languages and so forth, but I just can't remember off the top of my head. So maybe, Nikki, what I could do is just get someone to do a paragraph and I can send it.
Yeah, I mean, obviously we'd like a bit more information, even if it's a PowerPoint or if there's a link to something, or maybe even in September when you'll come back to us. But yeah, more details about how it'll work, plus that very important question about all those who need to access it. Okay, thank you. Oh, right. Oh yes, Tony, you're next.
Thank you, Chair. I've had some experiences at Hillingdon Hospital lately, and I must say it's been very, very good.
Thank you.
And in all aspects as well. But just a couple of questions I've got. You talked about the frail staff moving patients out of the hospital. I know bed blocking was a problem a few years ago. Is it still an ongoing problem in the hospital?
So what I was describing is, so we have a number of pathways for people who are regarded as frail, and we use the term frailty now because actually you can be frail and be 50, and you can be frail and be 95, and you'll see that from bringing patients into hospital. You can have a very unwell, frail 50-year-old and a 95 who's marching into the hospital and telling the ambulance service what they need to do. If it was my mother, that would be the case anyway. What we've done is we've looked at how we segment patients when they come to the hospital. So we now have a frailty service at the front door. So it's actually on Rockwood Ward, which is in the Tower block. But that's a service where a consultant, a care of the elderly consultant, and a team wrapped around them literally scoop up patients. So we did an arrangement when it was down near to ED where the ambulance service would say, we think we've got someone who's coming from a care home, you probably just need a consultant to see them, we'll bring them direct to you, and then what they do is they do the tests rapidly. If they've had a fall and banged their head, they'll get their CT scan done really quickly. If there's no evidence of a bleed or any damage, then they can get them back home very quickly. So it's the idea of having a senior decision maker at the front of the hospital who can do a very rapid assessment and then get that person back to home. And that is absolutely the best, because if you've got somebody who's had a fall at home but actually they haven't had a bleed, their family are just worried about them, then that rapid CT scan, some additional community support put in, or some extra carers put in, can make a huge, huge difference. So that's one bit of the pathway, and that's proving to be very effective, that senior decision at the front door. Then we've got a unit which is about people who might need a few more tests, a bit more assessment, maybe some physiotherapy or occupational therapy input, where we aim to keep them for about 72 hours. And then we have our longer stay wards, where someone has a particular condition. They may have had a stroke or something like that, and they're going to have a longer care journey, and we would expect them to be in a specialist area for a longer period of time, and they're getting a very different type of input. Where you're talking about bed blockers, and it's not a term we use anymore, because actually if you need to be in hospital, you need to be in hospital. But what we have been doing is that we've been identifying that there are people who are no longer need a medical input, but they might need a care package at home, or they might be in a residential home and they need to go into a care home. And those are the people where we've been working very closely with CNWL and with the local authority about making sure that those patients don't stay in hospital when they're ready to go home. And we spend a lot of time unblocking things in the system. So things like, my heating's not working, so I can't go home. Okay, can we get a handyman in to get your heating working so that you can get home? You know, you were on a 3 times a day package of care, but you probably need 4 now. How can we expedite getting that to happen? And that's something we do very effectively in Hillingdon.
Thank you. That's interesting. And just a final question. And I mean, in the last few weeks, there's been a lot of publicity about beds in corridors and things like that. Can you assure us there's no beds in corridors at Hillingdon?
The answer is yes and no. So in the emergency department, as I think you're probably all aware, our emergency department is not big enough for the number of patients we see, and we have a system with the ambulance service where we do what's called cohorting. So if the ambulance service needs to offload patients and we don't have a cubicle to put them in, then we will cohort in corridors with an extra nurse or a member of the ambulance service, but usually an extra nurse looking after those patients. When our flow is going well, that's something we don't do. And Chris, you can probably give a sense of it. It's been much, much better recently.
Yeah, absolutely. And actually, in comparison to some of the other hospitals across London, I would say that Hillingdon really, we don't use it as much as others at all. But the process that is taking place with it is that those patients aren't left on their own there. You know, there is a clinician, one way or other, from ourselves or from the hospital that can make sure that there's no risk to those patients deteriorating.
If I can just say, and then in terms of the wards, there is a process that has been introduced nationally, which is known as +1ing. So if we are under a lot of pressure and we're having to balance the risk of somebody staying in A&E unnecessarily and therefore another patient can't come into A&E, or getting them to a ward where they may need to be admitted, what we do is that we, when the hospital is full, we then risk assess, and we've got a number of ward areas where we can put another bed in a bay, or we can change the configuration of the way the beds are so that more patients can be cared for in a particular area. It's very specifically risk assessed, and we only use it where we're under extreme pressure. So we have a grading system that we get to black, and if we're on black and we're having to work out whether a patient is better to be left in the emergency department and someone else can't come into the emergency department, or we +1 them on a ward where there are nursing staff, there are medical staff, and we usually try to do that knowing that there are patients going to be discharged from that ward, and as soon as the bed is available we would put them into it. So that was certainly a process that we used during the winter months. We do have some +1ing at the moment because we are still very busy. I think it's clear to see that we're not out of winter yet. But that's in extremis rather than that it's something we would think is a reasonable thing to do.
Thank you. You've been answering our questions for almost an hour now, so thank you so much. So the last person I have on my list is Rita, wants to come back with a question. Then we'll move on. You'll be glad to hear.
Lovely, thank you, Chair. Yes, Patricia, it'll be the last question. Just coming back to maternity, what have been or are the level of complaints you've had around maternity, and what has been the trend? If you know the answer now, fantastic. If not, maybe it's something we can have a look at. So just I want to know, is there a correlation between what we need to improve on and what the patients have been saying?
So the number of complaints I haven't seen a huge difference in the number of complaints. So I've been looking at that recently, actually, across the piece about how many complaints do we have. So the number of complaints we've had across the hospital over the winter months has increased quite significantly. So whereas we were having around 25 complaints a month. We've been hitting around 45 complaints a month. The majority of those complaints related to experience in the emergency department when we were particularly busy over the winter months, and I've seen that drop right back down. So just to explain, the complaints come into the hospital, they go to our complaints team, they're fully investigated, but I sign off every complaint. So I get the investigation report, I get the original complaint, and I sign off the complaint letter. And so I would say that there are two things that have really increased the number of complaints we've got. One is around experience in the emergency department, which you can absolutely see a drop off in that since our flow has improved. And the other one relates to the introduction of our electronic patient record system, because it has made things a bit slower. So some of the clinicians are slower. We've had a few complaints about clinicians looking at their computer and not looking at the patient. And a number of complaints about the quality of our letters that go to patients. So that's one of the things with Doctor that will improve. In terms of maternity, not seen a big change in our maternity complaints. The themes are actually, as you would expect, and are being reported around the country. So things around individual experience of their care, issues around communication, and I think we've touched on that this evening, and not just about in their language, just general communication about my pathway of care. And that's actually a theme of a lot of our complaints, actually, is, you know, you didn't tell me what was happening with my dad, you didn't tell me what was happening with my care, and that's absolutely an area we need to do more on. So nothing, but in response to your question, are the themes that we've recognised we do need to do more on? Yes, absolutely.
Thank you, Chair. Maybe something that we can look further down the line.
Yeah, definitely. Thank you. Okay, Patricia, thank you so much for answering all our questions so far. So you're welcome to stay as long as you want, but obviously if you need to leave during the meeting, yeah, of course, you're very welcome to. I'd like to move on next to Chris Reed and Clinton Beale from London Ambulance Service.
Thank you, and good evening. So the first thing that, if I may, like to update you on is our recent staff survey results. This time last year, I was briefing you on a new model that we were going to introduce into the ambulance world of teams-based working, and this has been something that's been going on for a while now, and actually it's really nice to be able to see the outcomes from this. I'm particularly proud of our staff survey results, not only over the Trust, but specifically to the Hillingdon Group as well. We've seen increases in a number of areas in a positive light. With some of the statistics in the update there, almost everything went up since last year, and you know, this is from the hard work of the team at the Hillingdon Group. So really very pleased to see these changes that we're doing having a positive result. The full report is out there for anyone to watch, and I'm happy to sort of field any questions. There are areas that we'd like to work on. There are areas of concern. And that's absolutely what I'll endeavour to do for the next year for the Hillingdon Group. But overall, good progress. And I think there's something that, you know, over the sort of, this is my 22nd year in the emergency services in London. I've never been involved in such changes that have been taking place, innovative changes that are going on. And Patricia's just leaving, but I really want to say thank you to her, because a lot of our changes impact the hospital. And we you're leaving just but impact the hospital, and I'll give a couple of examples shortly, and they deal with it in such a remarkable way for things that one particular thing that I'll talk about in a second is our stroke pathway. We introduced the 45-minute where our clinicians leave the patient with the hospital so that we can answer people. And you know, these are huge changes that they've responded, and the emergency team have dealt with very well. But as I said, the ambulance service has really moved into an area where we are realising the external changes and responding to them. And so there's been a number of trials that we've been taking place and looking to move. And this is making it more centralised to the area of Hillingdon that we work on. Historically, we were centralised as a trust. We're now moving into an area where actually we work as Hillingdon overall. And we're seeing greater autonomy for our managers, greater care of our equipment, more bespoke care for our patients, and this is really, really exciting times, I'll be honest, for Hillingdon. Historically, everything was sort of trust-driven, and we worked in silos, and so this is a new time. So one of these is our fleet of vehicles. We're now tethering, so we have X amount of ambulances that work in the Hillingdon Group, and what we've seen already is how we're looking after these a lot more. And so therefore we have more vehicles out on the road. These vehicles are doing hundreds of thousands of miles a year. They're out 24/7, and so it's really important that we look after them. And so that we now intelligently resource. So I look at it twice a week with my support manager to make sure that we're not getting people in on overtime when there isn't a vehicle available to them. So it's a financial aspect to it. But having said that, we are getting a number of brand new ambulances coming in. All of them, unfortunately, need everyone being trained up in their new ways that they work. But this is making sure that we're keeping up to the demands of the local borough. One particular trial, like I say, we're trialling lots of new things, making sure that we're keeping up to date. But one thing that I would like to talk about is the clinical trial regarding stroke care. And this is quite exciting. This is where we're bringing in technology to make sure that we're getting the patients the right possible care. So we're talking about specific things here rather than an overview, and I'm happy to take any questions, but this one I'm particularly excited about. So historically, anyone who was fast positive, so the typical symptoms that you see on the television where you have a facial droop, slurred speech, or arm drooping on one side, would be going to the stroke unit at Northwick Park. Now, that's not always appropriate for every patient because they're not appropriate for thrombolysis or might not be appropriate for thrombectomy. What we're doing now is that we have an app where we make contact with a stroke consultant there and then with the patient. We give a good handover to that stroke, and therefore we can free up the pathway to make sure these patients are seen and get to CT and get thrombolysis a lot quicker. There is a lot of conditions that mask stroke symptoms, one being Bell's palsy, and what we've found is that our clinicians are taking these patients, and they're not having a stroke, but they mimic that fast positive, and we're clogging up the system. So this means that they're all grades of clinicians, because we have a variety from advanced paramedics to assistant practitioners. That means that we're not clogging up the system, and we're getting the right people the right care. Really excited about that. Hopefully by next time I'll give you a bit of an update. We're only a couple of weeks into it, but we're already seeing good results. The consultants from Queen Square are picking up very quickly, and we're being able to have that conversation about what is the right care for our patient. Response times are always going to be something that we'll always focus on, whatever they are, and they come and go. But I'm pleased to report that over in northwest London, the average response time for our Category 1 patients, our sickest patients, is 7 minutes and 5 seconds. And that's, I really do want to highlight how difficult that is to achieve. That's when the call is connected. So no words have been said between the person calling and the operator. So we have 7 minutes, so it's just outside our government target by 5 seconds for North East, but that's getting someone to that patient within that time. And we haven't even talked about an address or anything like that. And that's done by monitoring our fast response unit, making sure constantly they're in the right part of the London on standby to make sure that we get to those patients quickly. So always work to be done. We'll never not have work to be done and getting to our patients as quick as we can. But for our sickest patients, I am pleased that we're 7 minutes is a difficult ask, but we're getting close to what we want. Another little bit of highlights for us is, and something I'm particularly proud of at Hillingdon as well, is making sure that we are doing the right thing for our patients, our sickest patients. Now, half the time they need to get to definitive care. They need to get there. We're not going to be able to do the surgeries there, and so that's making sure we're not hanging around on scene when they need to be in a major trauma unit, a stroke unit, a HASU, a cardiac unit like yourselves up in Harefield. And actually we can report that we are the quickest borough to get people away on scene for the blue call. Do you have a question? Sorry, Councillor.
No, I'm just indicating in due course. No.
Oh, sorry. Apologies. I'm happy to take questions as and when. So really quite, this is something we because on-scene times is something we monitor quite regularly. However, for the non-critical patient, the ones we're not blue lighting and pre-alerting the hospital, it's not always about how quick we are on scene. This is about getting them to the right care. And this is a difficult one to make, one to just make sure we're doing it as quick as we can, because actually that doesn't always mean it's the right thing. We try and avoid the ED department when it's appropriate. And this is where we're using things like the frailty unit and having and actually, again, Patricia's left unfortunately now, but actually out of all the appropriate care pathways, the ones I'm hearing the most positive engagement with is actually that frailty unit. Some of them are challenging when we're trying to get hold of GPs, some of them are rapid response teams. It's difficult depending on the time of day. We're working through that and working when there is a difficulty. We can address that on an individual basis or if there's trends. So sometimes having that handover and making sure that patient gets the right care takes time on scene. So we're not always trying to champion the quickest time on scene. It's appropriate care for the non-critical patients. So if I could just clarify that. Quality is also something that we keep an eye on. There are some figures there that we constantly keep a monitor on in terms of the indicators that we're making sure we're doing right by these key patients as well. I won't bore you with the details, they're all in the update, but again, something that we constantly are monitoring to make sure we're covering and making sure that quality is still high. I'll stop there for any questions.
Fantastic, thank you. I really enjoy listening to what you tell us about innovation and always thinking about moving and improving to get people to the right place or deal with them the right way. And you know, obviously a lot of stuff has been in the news about ambulance being parked in hospitals, all this sort of stuff, but it's really good to hear about what seems to be a positive relationship with Hillingdon Hospital in order how to get people to the right place as quickly as possible. So that's all really good stuff. I've got there's one question in my mind which you may not be able to answer actually, but I was thinking back to last autumn when the Metropolitan Police came up with their right care, right person strategy, and obviously for those who don't know, that was the concept that the Met Police would not necessarily always go to where, if there was a call with somebody who had mental health issues and in distress, I mean, rightly from their point of view, resources were being used in a place that maybe they didn't feel like they should be using them. Now, at the time, there was a concern that it might impact, obviously, on other services, especially ambulance staff, who'd have to go maybe deal with people not feeling completely safe, or ambulance staff and ambulances having to instead wait longer rather than the police waiting longer. So I just wondered, have you noticed any changes since the right care, right person strategy has come in, and are you still happy with the support you get from the police?
Overall, yes. To that question, yes, we are pleased with the support that we get, and this was absolutely the right move by the police. This isn't something the LAS opposed. I'll be clear on that. We quite often, these people who are going through a mental health crisis can exacerbate their condition if the police turn up, and that's the uniform. And they know that. The police know that, and that's the last thing they want to do. We have incidents, sadly, where our staff are assaulted, and it's not just with mental health patients, but it's with intoxicated patients. You know, that is day to day. And I'm pleased to say on the majority of cases, and when we request the police, they're there for us. So there will always be one or two that are just unpredictable and difficult to deal with. What we are doing as well is, in the next couple of months, isn't it, we're setting up a mental health car for the northwest of London. It will be working out of the Hanwell Group, and these people will be dealing with the mental health calls solely. So this can mean that we can train them up better to understand, because we really are a jack of all trades. We deliver babies, we go to mental health, we go to car crashes. You know, we're specialists of none, but jack of all trades, and we do our best with that. But sometimes we do need to specialise. Mental health is a really difficult area of work, especially out of hospital when we have to consider capacity, we have to consider the right thing for the patient, we have to consider the ongoing care, and these are clinicians that have got to make pretty rapid decisions without not knowing everything and making sure that patient is safe. And capacity is a big part of this, to make sure if they're refusing to go in, you know, taking them against their will is a massive deal, and something we need to get right if that's required. And so a huge amount of training needs to go into that, and we do have specialist. We have the clinical hub that we can give advice to our younger clinicians on. We have clinical leaders in each group. But what's a positive thing about the mental health car that will be taking place soon is that we can just build on any experience for those clinicians, so they get better and better and better with their knowledge base on this. and these will be going soon. So hopefully in the next update, I'll be able to give a little bit more feedback on how that's going. I think we're putting out expressions of interest as we speak, aren't we, for the right people to get on that. We want the right clinicians who have got an interest in mental health to go out to these patients and gain their experience. So hopefully we'll see a bit of improvement in that area. So overall, I haven't personally heard of any detriment of the right care programme that the police has done, and like I say, on the majority of cases, if we do need them, they're there.
Thank you. We look forward to hearing more about how the mental health car works. Sounds really good.
Thank you.
Philip.
Thank you. A couple of things. First of all, it's pleasing to note the staff survey results, and I'm sure Hillingdon would be delighted with that level of recommendation from their own staff. Clearly they're working on it. Let's not be too unkind, but it's good that you've achieved that yourself, certainly.
Thank you, very proud.
I do want to ask about the championing the alternative use of care pathways. So you've touched on that here. I'm just interested in understanding a little bit more about what that looks like, because one assumes that you get the odd call, which is entirely inappropriate for you to deal with, and where perhaps people could be supported in other ways. So I wonder how big a problem that is, and perhaps give us one or two examples about these alternative pathways that you're helping champion. Thank you.
No, thank you. It's a good opportunity to be able to talk about it, actually, because the odd call is probably generously putting it, if I'm honest. But we never take away that's their patient's hour of need. Does that make sense? So what might be a routine call for us isn't for that patient. We can't take away any patient, no. And we're happy to be there for them if they call 999. Even if it isn't a critical illness, that's their time of need, and we recognise that. That's important. So we go there with empathy, we go there with compassion and good assessment. We don't take any of that for granted. We have a variety of alternative care pathways. Some are on the acute stage, like the stroke units, the cath labs at Harefield, the major trauma unit at St Mary's. But then some are on the other end of the spectrum, like rapid response teams, district nurses, the frailty unit, SDEC, some of the ones within the hospital. And each of these, through the Medical Directorate of the London Ambulance Service, help have guidelines of what's appropriate, what conditions they take and what they don't. And again, it is a little bit of jack of all trades, where there's an abundance of these that the clinician needs to be trained up on what it is. And we do this through our training days, where a clinical team manager will lead their team of approximately 20 clinicians every Monday. It's every 9 weeks we have a training day, and this is quite often a common theme to make sure we're referring the correct patients to these alternative care pathways. What it involves is when you're on scene and you decide that the emergency department is not the best option for this patient, is making contact with whatever alternative care pathway it is, whether it's a district nurse, whether it's a frailty unit, or whether it's SDEC, whether it's any of the others, the plethora of ones we have, the midwife-led care. We make sure we have a clinician-to-clinician handover over the telephone, where we use an S-bar handover to make sure that they're fully briefed on what the condition is. And then we work out how we're going to get that patient to it, whether it is as simply as go tomorrow, or whether it is we'll take you straight there. It does require a lot of training. It requires a lot of making sure that we're doing the right thing, safety netting that patient if we are leaving them without further care, and that's all part of the training that we give our clinicians.
Thanks, Philip. June.
Thanks, Chris.
Hi.
Glad to hear that you're blending in with the changes that's happening. I'm sure it's a heavy load you guys got to carry, but doing it very well. My question will be on the staff sickness. And as you said, it's being jack of all trades. Does that impact on the staff that causes the staff sickness with all the changes that's happening? Or what is causing the staff sickness?
It's really good. It's something we need to consider with all these changes. We monitor sickness quite strongly. It's changed since I put the report in. I write this report a good few weeks before we're here today, knowing that full well that figure's probably changed by the time today. One of the biggest reasons of of sickness within the London Ambulance Service is stress. Then musculoskeletal injuries from the physicality of the job sometimes, and these are the two things that we work on. Since COVID, the London Ambulance Service has introduced what we call the Wellbeing Hub. And this has made huge progress and gets bigger and bigger and bigger, but it gives our staff numerous options through physio, through psychotherapists, and making it really accessible for help that they need. We have a robust sickness policy in making sure that we're there for our staff, but also making sure that that sickness is managed and it's appropriate for the needs of the borough as well. It's something we constantly monitor. It's something we're constantly looking at the reasons. We look at trends as well, and so we never take anything off the table. If the changes that we're doing is something that we think, we'll monitor it and look at it. We'll consider it. I don't think that's the issue at the moment. I honestly think that actually it is the nature of the work sometimes. These young clinicians are going out, and we have people starting really from sort of 18, 19 as students, going out some horrific calls. And sometimes just the impact of that day and night leads to sickness. And it's something that's constantly monitored.
Thank you. Tony.
Thank you, Chair. Thank you, Chris, for the report. It's very encouraging and good to see. The only thing I couldn't see in there was, because I know it's been a problem in the past, is the staff turnover and the recruitment, any recruitment issues for Hillingdon.
We're getting more staff now than we probably ever have. I can get some numbers for you in due course. What the difficult we find is how do I put this? It is getting experienced staff to stay in the role. The trouble is, unfortunately, this isn't a job that you can do for life now on the road due to the physicality of it. So naturally, some go into management, some you need to sort of, the physicality of it does make sure, and also that because we are a jack of all trades, there are more career options. We're used in GP surgeries, we're used in prisons, and so it's a difficult one for me to answer because I always want staff to develop and move on and gain experience in other areas. And we've got a whole host of departments within the London Ambulance Service to go out there. But keeping experienced Band 6 paramedics on the road is a challenge. It is a challenge. I'm not really sure of the fix because I also want to develop them.
Yeah, if we could have some figures on the turnover, that would be useful.
Certainly.
Thank you very much. Still.
Thank you, Chair. Thank you, as always. I really do enjoy when you come here and talk to us about all the innovation that goes on and all the processes that you're doing. I'm just really happy to hear about the Wellbeing Hub because I know pastoral care is something that you have brought into this, and that is really important. I was just going to say a couple of comments on what you've said first before I ask my question. I just wanted to echo how welcome it is that actually it's not just about how quickly you respond to something and how quickly you move on, but actually what is appropriate for the incident at the time. Being quite a horrific car crash in January, I was grateful for the paramedics to spend time with us and not move us on because we weren't able to be moved on. And the empathy and care that was shown was absolutely phenomenal, especially towards children that were involved in that car crash as well. So that, again, phenomenal service that is being delivered. When coming down to the sickness element, what I wanted to understand from that, as I always do, is where do the staff come from? Because it's a very, very specialised field in what you do, being jack of all trades. Where do that staff come from if you've got a fleet of like 5-6 people coming in that going, I can't come into work today, or I can't, how do you fill those shifts up?
Mainly through overtime. Genuinely. So we and this is part of the innovative things that we're looking to do more centrally to Hillingdon rather than centralised over the whole of the trust, is that we look twice a week at actually our resourcing moving forward. If we have gaps, we open up the overtime flags and we put it out to staff that might want to work an extra shift. Sometimes if it's not taken up, we just have 1 or 2 less ambulances on the road. But thankfully, because we're not tethered at the moment to the borough, I say at the moment there's no plans of moving anyway, but the nearest ambulance goes, and sometimes one of our ambulances in Hillingdon could end up in Newham by the end of the day, because if the most appropriate hospital is Charing Cross, you get a call in West 1, then you move into Tommy's, and do you see what we can migrate across London? So sometimes there is there's just less ambulances on the road, but most of the time we cover that through overtime.
If I can follow that up, what does that mean for, because you're talking about stress and you're talking about physicality, so once you go into overtime and you're doing that extra shift or maybe 3 extra shifts because you might need to do those extra shifts, what does that mean on that person?
It absolutely varies person to person, but what we do is make sure that the working time directives are not being breached. We have people that 1 or 2 extra shifts, and we've got home life has a massive impact on people's energy levels and things like that. And what I'm proud of at Hillingdon and from teams-based working is that one manager now knows their staff inside out. And we didn't have that before. We had managers ad hoc on their rota, we had staff ad hoc, and although they had a good overview of our set of staff, we have about 170 at the Hillingdon station in Royal Lane. But now that we're really going down to 1 in 20, they'll know if there's an issue, and we can actually have that one-to-one chat with the manager and that staff member to see, are you overdoing it? Are you, let's have a look at your rotas. Is there anything that you need? We've got these wellbeing. What's the thing? Financial, incentives sometimes really does make people do too many shifts, and we're not afraid to step in and cancel a shift. I've done it a couple of times. You're doing too many, we're stopping it. So we do keep a close eye and absolutely aware that people do burn out because of the financial need in the current climate. It's something we keep an eye on. It's a very good point.
I just wanted to go on to the Cerner that the hospital were doing, and kind of wanted to know what LAS's kind of involvement with that is, because that is, if they're using it and they're doing it across the trust, is something that the clinicians or the people and paramedics have access to as well, so you kind of are talking to them and being able to pass that information and input into that system?
So at the moment, across London, we just changed our system to an electronic system last year, and that system reads into all of the systems that are currently used across London. It's done as a PDF level, essentially, so we create our paperwork and then we fire it off into the internet, and it basically then can be downloaded, essentially. But just to give the assurance to the board that there is a piece of work that's being done now. We're a year into our project. There's now another project that's now about to kick off, which is called Transfer of Care. And what that essentially is doing is that will put all of our data directly into any hospital system. Obviously, there's safety netting and patient governance processes in place. And one hospital in North West London will be trialling that in the next couple of months. And that will and that's just about improving the speed and processes and the safety of that data as it goes across.
Thank you. Rita.
I don't have questions so much as an observation, Chris. Firstly, thank you very much. You're always very positive when you come here with the feedback that you give, and also commend you on your 22 years in doing your role, which is a very challenging role.
Thank you.
Really well done. So I'm looking forward to the next time we meet and hearing about the stroke unit, because it's critical, as you said, that if you get the care as quickly as you can, your recovery is better.
100%. So, yeah, really passionate about that. It's exciting times.
Being optimistic and positive after working somewhere for 22 years should be noted.
I must say, it's not always with the ambulance service. I was 4 years as a police officer as well.
Okay,
so
fair
yeah.
Okay, well, thanks very much. There is cake over there as a reward.
Thank you very much. Happy birthday in August.
Thank you so much for that. So we'll now move on to Piers McCleary from the Royal Brompton and Harefield Hospital. Piers.
Great. Thank you very much for having me this evening. I'm standing in for Derval Russell, who's the site director at Harefield, who normally would be, this is her report. And if you give me the permission, I'm not going to sort of talk exclusively to this report. I will refer to a couple of things, but I'd like to give you a sort of a flavour a little beyond that, because my role is Director of Strategy for what we call, it's a horrible name, Heart, Lung and Critical Care Clinical Group. As you may know, Brompton and Harefield NHS Foundation Trust was merged into Guy's and Thomas's back in 2021. And Royal Brompton and Harefield Hospitals are part of what we call a clinical group within the behemoth that is Guy's and Thomas's, which now turns over in income terms something like 2.6 billion. It's not quite the largest trust in the country. I think Manchester is, but it's one of the largest of such trusts. And there are 4 clinical groups. Our clinical groups, as the name says, we specialise in cardiovascular, respiratory and critical care, principally at the tertiary and quaternary level. And I'm the Director of Strategy across that group. I'm going to start, if I may, on the topic of strategy and kind of give you some reassurance that we are heading in the right direction. We merged 3 years ago with the rationale being about if we could come together and we could create economies of scale around subspecialization. So what does that mean? If you take something like cardiovascular medicine, you will have within, which is a specialty in its own right, you'll have a subspecialty which might be cardiac surgery. But within cardiac surgery, you will have surgeons who specialize in revascularization, which is sorting out your coronaries, structural heart, and some of the, which is your heart valves principally, and some surgeons just focus on the mitral valve and don't touch the aortic valve and so forth. And some surgeons also just focus on the aorta, which is the main artery coming out of the heart. And even with arterial aortic surgery, some surgeons even subspecialize in the arch and the descending aorta rather than the ascending aorta and so on. When you subspecialize, you tend to get better outcomes because you have a particular interest, and it's not just a single surgeon, it's the whole multidisciplinary team. Surgeons, anaesthetists, radiologists, physios, nurses, pharmacists, and so forth. You develop a real expertise and understanding of a particular group of patients. And not only do you tend to get better outcomes, you also tend to attract talent, clinical talent, which I can come on to, and as these guys have just said, trying to recruit and retain the right talent for clinical scientific talent is probably our biggest headache, and it will remain so for the foreseeable future. By coming together with the teams at St Thomas's and Guy's, we have probably the largest cardiac interventional centre together across our 3 sites in the country. We do well over 3,000 cardiac surgeries a year, and that's not including congenital, which is another 600 on top of 500 on top of that. And that scale enables at that subspecialty area level to really attract some amazing clinicians. It enables us to do research because we have the size of cohort that we can then do valid research on particular subgroups within these subspecialties. So scale really matters, and there's a real opportunity for us, and this was the rationale of the whole merger and why I'm going to be blunt here. It's a painful process coming together, mergers of 2 cultures coming together, and we are clinically very much aligned, but managerially, the old Brompton-Harefield way of doing things was slightly different to the way in which the Guy's and Thomas's way of doing things. And after 3 years, we are getting onto the same page. And despite all the frustrations that are associated with that, we genuinely believe that what we can create is something not far off unique, not just in Europe, but perhaps worldwide. The potential is really, really exciting, but I have to admit we're in the foothills of the Himalayas, if I'm brutally honest with you. So where we are, we're trying to put together a strategy, which I would very much hope to bring here at some point, where our USP, you would hope that something as unique and of this scale would have some sort of unique selling point. And it's very much around the depth of the knowledge and the know-how, clinical and scientific know-how we have within each subspecialty and across a very, very broad range of subspecialties within cardiovascular, within respiratory, and then within critical care. So that's to assure you that the logic behind the merger was a good thing. It's bumpy culturally and is going to remain bumpy for a while, but if you like, the vision is still a fantastic one. I want to touch on 2 or 3 other things. Derval in her report talked about an exciting trial around cancer at the Brompton. What it perhaps doesn't give us a sense is that this is a world first. We were the first NHS centre in the country to get use of a new robot called the ION robot. It's made by an American company, Intuitive. What this robot enables you to do is when you normally do a biopsy through a bronchoscopy of your lung, you put a tube down into your airways and you try to reach what you think is probably, but you don't know for sure and you need to diagnose it, is a lung tumour, a cancer tumour. And normally, to be able to do this by hand, the tumour has to, or the lump, the suspected tumour, it has to be at least 25 millimetres, maybe 20 millimetres for you to be, for even the most skilled of our interventional bronchoscopists, to be able to hit it, take the biopsy, then take it out, put it under a pathology slide and say, oh, that is malignant, let's put the person onto the thoracic surgical wait list. The amazing thing about this robot is that you can, with way more precision and miniaturization of movement, you can take that biopsy from when the tumour is way smaller. So when it's as small as 6 millimetres. The amazing thing about that is that the survival, if you can take a biopsy and confirm that it is malignant when it's 6 millimetres, your survival at 5 years is something like 95%, if you then go on to have the tumour removed. If you wait till it's 25 or 30 millimetres, the survival is about 65%. So there's an enormous difference. There's a downside and then an upside. The downside to this is that when you take a biopsy of a 5 millimetre or 6 millimetre tumour, you don't know the likelihood that it is a benign tumour is that much greater. You tend to, if a tumour gets to 3 centimetres wide, there's a much better chance that it is malignant. On the other hand, you don't want to leave it to grow to 30 millimetres because your survival prospects are less good. So if you like, there's a health economics downside to tackling these tumours when they are very, very small. The upside to that, and this is why this trial is so exciting, if you can then combine the situation when, if you've taken the biopsy of, say, a 6 millimetre wide tumour and you've worked out it is malignant, we're now in a position for some of, or many of the tumours to be able to do what's called an ablation. And there and then, under the same anaesthetic, with exactly the same delivered through the robot, but with a slightly different probe on the end of the catheter, you can then literally burn the tumour off at that moment. So it's both diagnostic and therapeutic, and indeed, we believe, although we've just started doing it, curative all at the same time. And the economics of that, from a health economics perspective, will be, we think, pretty stellar. So that's a really exciting piece of robotics that's going on. We are just about to conclude a business case into it. It's putting in a surgical robot at the Brompton, which we're going to get Harefield colleagues to use initially for lung cancer surgery. We are a laggard in this. We are about 23rd out of 27 thoracic surgical centres in the UK to be doing robotic thoracic surgery. I could go into the reasons why if you want. The exciting thing is, though, that our cardiac surgeons, many of whom are already trained on minimally invasive mitral valve surgery and aortic valve surgery, we are going to make a decision that we will be using this robot too for cardiac surgery. Why I'm mentioning this is that the robot is not yet approved in Europe for usage on cardiac patients. It is approved in America. It is widely used in America with very good results for cardiac surgery. For corporate reasons, the company has not gone ahead and got it UKCA marked in Europe. There's a team at Barts who are using the robot, an earlier generation of robot for cardiac surgery. This is a more advanced robot, but the company hasn't yet got it UKCA marked. But we're pretty determined that with the appropriate, very careful governance, very careful proctorship, we want to be using this for cardiac surgery within the next year. Transplantation I will touch on, which is in the report. This has been a phenomenally successful last year. We were the largest, or we achieved the largest number of heart transplants in the country. I have to give the credit to a guy called Professor John Dunning, who came in 3 years ago. He originally was with Papworth. He went to America, and we managed to lure him over here. He's kind of, if you like, a wanderer. He's now left us. He's gone back to America. What he's done is put the program on a very, very strong footing. We now have 2 leaders. One, Fernando Rees-Gill, who's in charge of the heart transplant program, and Dr. Vicky Garasavili, who's in charge of the lung program. It's on a really, really strong footing. We're looking at the economics of how we can afford a new technique called ex vivo lung perfusion, which would increase by about 30% the number of lungs that we can accept for lung transplantation. So we expect that number of lungs to be within 1 to 2 years if we can make the economics of this work. It's not yet a commissioned product, and it's I'm not being flippant, ludicrously expensive for what it is, £25,000 per usage. But it is an amazing piece of technology, and if it gives us another 30% of lungs that we can use, then that's pretty fantastic. But we've got to find a way of affording it outside of commissioning money. It's not all good. Areas for improvement. And back to the Derval's report. Our sort of P2 cardiac surgery wait list is a cause for concern. It's that everybody, all P2s, they're the sort of most urgent patients, well, second most urgent. We aim to see them and operate on them within 4 weeks. We are probably nearer 6 to 8 weeks on average. That is a function, as Derval's correctly noted, about the complexity of the patients, something I picked up when Patricia was talking about some of the maternity patients, but the complexity of the patients that we're getting, and the sheer number of referrals. I think that is bluntly still a factor of COVID, a backlog that's been built up. We were the first centre in the country of the 27 during COVID to adopt a way of monitoring through an app called Ortus. Well, it wasn't called Ortus, it was a Humour app. And we pioneered it with this company called Humour, and it's a way in which a text goes out to every single patient on our wait list, and once a week, and it asks 9 questions, and based on the answers to those 9 questions, one of our cardiac specialist nurses then calls the patient up, does a further triage, and then adjusts them on the wait list according to their symptoms. And we were the first centre in the country to adopt that. So we're doing what we can, and Derval's noted some of the weekend lists and so forth, but it is a cause of concern, the size of that P2 wait list. And I think if you asked any London or even national cardiac surgical centre, they would have a similar concern. Epic. We've talked about electronic health records. I'm not suggesting you should, but if you read the Health Service Journal, there was the Chief Financial Officer of the Royal Devon and Cornwall NHS Trust saying that they too have had Epic, and it's a Rolls-Royce that they are currently driving like a Ford Focus. I think that's rather hard on Ford Focuses personally, which is a great car. There have been times when we, with our implementation of Epic, have been driving it like a Trabant, if not us. It is an incredible system. The volume of data that it can capture is quite astonishing. And long term, we will be able to do some truly amazingly research. When we are able to combine it too with, Patricia made a good point, a lot of the data which comes in for us to make an assessment at one of our multidisciplinary team meetings, which is where you've done the diagnostics and you're now deciding what is the right path of treatment for the patient. Something like, because we're a tertiary referral centre, something like 50% of the data on a typical pathway comes from outside Epic, so outside our centre, outside our hospitals. And it comes in the form of PDFs, it comes in the form of photocopied letters. Now, there are technologies out there, and we've tried very hard with a collaboration with IBM to try and learn to turn that, what we call unstructured data that's in those PDFs and those scanned copies, into structured data. And once you've got it into a structured form, you can then combine it with something like the EPIC data, which is already in structured form. And then you can start to do things like clever analytics that sort of say, right, here's a group of patients with this set of characteristics. Typically, they should have that set of outcomes. Why, therefore, are these 10 outliers? And that's where ultimately the power of the sort of AI and machine learning will come. We are a mile off from that at the moment, largely because we're still learning to do the basics within EPIC. We haven't yet. There are no reliable technologies out in the market for converting really reliably with sort of 99% accuracy, converting unstructured data into structured, which is all, if you like, the wealth of the other data outside our own hospital systems. We are getting better at the basic usage of driving EPIC. A way of saying it is when we went live, it took our staff 2 times as long to do what they had done before EPIC. It's probably down to about 1.1, sometimes 0.9 of the time it took to do it before EPIC. We will get a lot better. It's an amazing system. I have to admit that the train in hindsight, we should have negotiated much better for more post-implementation support. We have the experts, our own homegrown experts. We just don't have enough of them at the moment. And lastly, I think resourcing. We take too tactical a view of resourcing. We will suddenly say, help, we're short on theatre nurses. We can't run a theatre. And at the Brompton about a year ago, we only had 5 out of 6 theatres operating for 3 or 4 months because we didn't have sufficient theatre nurses. And we tend to be very short-termist. And we're trying now to think, particularly now as we are part of this much bigger clinical group, how we reach forward upstream, if you like, into secondary education colleges and so forth, to say, yes, there's medicine and yes, there's nursing, but there's also technical roles. There's things like cardiac physiologists, who are the people who man the cath labs and operate the fluoroscopy equipment. There are echo technicians, people who run the echocardiogram, lung function technicians who operate the lung function machine, and so forth. These are really actually interesting careers. They offer, in some cases, the opportunity for private practice as well, so you can get quite remunerated as well. And these are particularly hard cohorts of staff to recruit and to retain. And we're having to think up more and more. We should be starting to think much more strategically long-term about how we attract these people in the first place, and then be much more, if you like, creative about what we can offer them by way of a portfolio of activity. So clinical service, especially take an intensive care nurse, is incredibly hard work. It is incredibly demanding. You burn out. One of the things we're trying to introduce is the ability to rotate people through research roles, for example, to give that bit of variation that perhaps allows us to retain those staff a bit longer. It's early days, and we've had 1 or 2 successes, but there's a lot more that we need to do on that. I'll stop.
Thank you so much. That's very interesting to hear from you, especially from your perspective as Director of Planning and Strategy. I've got one question, which is sort of a broad question, really. So the Royal in Brompton is small, it's excellent, obviously specialist, and we're very proud to have it in Hillingdon. And Guy's and St Thomas's is big, and obviously the opportunity is scaling up the excellent. The risk is being merged and lost in the big. And it's something I've asked Derval in the past, but I'd like to get your opinion on it. I mean, where do you think that balance is, and are you optimistic about the opportunities compared to that risk?
The risk is already crystallised in the sense that we are slower. So finance system, our invoicing system, is tediously slow. It takes us twice as long to pay an invoice. Clinician-wise, let me tell you, the clinicians at Guy's and Thomas's within our specialty areas are every bit as good as the Harefield and Brompton folk. There is no doubt about that. Sometimes some of the rather hoity-toity Brompton folks look and say, well, we're the Harrods and we're merged with Tesco, which you have to get a hand and give them a fairly sound clip round the ear. We don't get that with the Harefield folk, who have much more. I'm going into that. We won't go into it, but anyway, clinically and scientifically, Guys and Thomas's is excellent. Managerially, because they've had to manage before we merged them, they were a 1.7 billion turnover organisation, which is huge by anybody's standards, and they manage it all through a very centralised system. So that's conditioned a certain style of management. It's very protocolised. It's very rule-based. You don't show initiative. Well, you're not encouraged. Well, there's no encouragement to show initiative. You look at a very specialised, one very single bit of an administrative process without necessarily understanding what the end outcome is and what the frustrations are for the customer, as it were. Having said that, that degree of protocolisation is a good thing in that, if I was to be brutally honest, I'd say Brompton and Harefield, we did stuff, and then afterwards we kind of thought, oh, what was the evidence? We knew it was the right thing. We met as a multidisciplinary team to take the decision. Did we have, however, all of the protocols that we could have had in place to use as a guide rail for that? Perhaps not. And sometimes when we perhaps in hindsight weren't as good as we should have been at evidencing the good stuff that we had done through comprehensive sets of audits. We were good doers, but perhaps not as thorough, if you like, at evidencing all the great stuff that we did. And the good thing about the Guys and Thomas's culture is everything is protocolised, everything is rule-based, and so on. It's about achieving a happy medium between that. Have we achieved it? Certainly not. Will we achieve it? It depends if the clinical group model which prevails, which is all about Guys and Thomas's recognising that a £2.5 billion organisation you cannot run in a centralised way. You have to decentralise. You have to let the clinical groups have operational autonomy on a day-to-day basis. Yes, there are some things like capital allocation and strategy that need, if you like, the blessing and the steer from the central area. But that day-to-day we should be given, as a 700 million turnover business, we're mature enough and whatever experienced enough to be able to run things on a day-to-day basis. I think there's parts of the culture of Guys and Thomas's is not yet ready to do that, but give it time. Does that answer your question?
Yes, it does. I mean, it's an ongoing question, obviously. So, but thank you very much for that. I drive a Ford Focus, and the only thing I've bought in Harrods is a carrier bag, and I'm happy with my life. Philip, you wanted to ask a question.
I did. In fact, what I indicated, it was really to understand more about the subspecialties that we're developing. But of course, Piers, you went on to talk very interestingly at some length, which was really quite informative. So got a lot out of that. It's good to hear about the development of care pathways, diagnostic treatment, which obviously has enormous patient benefit and potential savings. So I won't ask you about that because you're very helpful to talk about. What I do want to just touch on, though, briefly, is just Harefield. And we, from time to time, we hear bits and pieces about the fitness of purpose of the estate and issues relating to it, constraints about it. I mean, is there anything you're able to say about that? Is there anything we need to know, or are we broadly content with the position within the trust that Harefield holds at the moment?
I think you should be very reassured that Harefield does things. So if you take the transplantation, what we'd call care for end-stage heart and lung patients, the other three hospitals cannot do that. Partly it's an expertise. It's about the breadth of the supporting interventional subspecialties. So we do have a big cardiac surgery program here, a big electrophysiology, a big heart attack program, a big device implantation team, a big thoracic cervical team. So there's scale that supports, if you like, that. Let's call it the jewel in the crown, the transplantation, the end-stage heart, lung and failure program. So the scale that Harefield has, more to the point, to run a transplantation program, end-stage lung and heart failure program, You need space. You need beds. You need a heck of a lot of beds. And there is no way in an inner city hospital like Thomas's, Guy's or Brompton that we can carve out that space. What we are in the middle of, and it's a good question, is alongside doing the, if you like, our clinical group strategy, we're also refreshing our clinical strategy for Harefield. It's kind of trying to say, during the pandemic, what Harefield did, it was, along with Barts, were the two centres in London that carried on doing cardiac surgery. Brompton ended up having to specialise in, because of ECMO, in care of very acutely unwell COVID patients. But Harefield kept that heart attack centre, the cardiac surgery and indeed heart attack centre going. So we, off the back of that, we were saying, sort of, what is Harefield's USP? And it now, we're more and more convinced that actually it is the way Harefield adds value to London, indeed London and the South East, is as the expert centre around managing end-stage heart and lung failure. So transplantation, LVADs, which is mechanical assist, backed by, and this is the important bit, and this is where the benefits of the merger we feel will kick in, backed by two academic programs, one about cardiac regeneration. There's an incredibly bright team at King's under a guy called Professor Mauro Giacca that is looking at how you can regenerate heart tissue. That's as far as I understand and I can go this evening, and it'd be good at some point for you to hear from him. We have the space at Harefield, and we've got the Magdi Yaqub Centre that we can repurpose, I think, to be a place where we can house that program. And on the lung side, we've got a group of researchers who are really, really experienced and talented at looking at managing the immune system reaction, which is the big thing in lung transplantation, managing that better in the future. And we're probably one of the leading, if not the leading centre on that particular piece of research into lung transplantation. So if you take that as the core purpose of Harefield, and you look at some realities around economics in that to refurb a square metre or rebuild, replace, build a new square metre of intensive care capacity at Harefield costs about £3,500–4,000 per square metre. If you did it at the Brompton, or God forbid, if you do it at Thomas's, it's about £12,000 to £14,000 per square metre, because there is just that more space at Harefield. The decant options are easier, etc., etc., etc. So as a place in which to expand capacity, not just for our particular clinical group, but for other, if you like, potential services within Guy's and Thomas's, Harefield has the space. Harefield also, fantastic, has great transport rings. When it comes to thinking about organ retrieval for heart and lung, proximity to M25, M40, M1, M4, it's an incredible location too. So where we are with our clinical strategy, we were revising that, and then out of that we want to put together a master plan which says these are the sorts of buildings we want to put to for the 21st century. Then we've got to think hard about how we fund that, and I think philanthropy will have to be a big part of it, but it won't be the only part. So all I can assure you is that Harefield is majorly a central part of our plans.
Thank you. Cecil.
Thank you, and thank you for coming in today, because that was just really, mind-blowing actually, and I'm really proud to have Harefield at hospital doing what it does in our borough. Derville comes in and talks about the building and the need for upgrade of the building quite, every time she comes in, really, and that's always a going concern. And this this merger with the Guy's and Thomas's was one of the things where there was a hope that there would be attracting funding, I believe, for the opportunities for this. So the master plan that you talk about in terms of the upgrade and the facilitation of expansion, do you feel that would kind of enable those kind of upgrades from technology to capacity happening? Because it feels like there is a lot of phenomenal work, a lot of opportunity, And also, it feels that, or it seems from what you're saying, that actually in this merger, Guy's and St Thomas's also has come on board. It's not followed up by a big person on the bottom. They've got you've got something that they need, which is probably capacity and speciality. So therefore, their funding kind of could be streamlined in different ways.
If only. They have a huge estate. Guys, they have not just the two hospitals, Guy's and Thomas's. They have something like, I should know this number, it's either 29, 45 or 100. I forget which number it is, community centres, all over South London. It is huge. They have a list of estates issues longer than anybody's arm. I think so when Derval comes here, she'll say, yes, we have Oak and Acorn wards were put in. I remember the business case for Acorn, I think it was 2012. It's now 12 years old, which is a modular build. It's long exceeded its expected lifespan. We've got thoughts about how we replace it. It'll be tens of millions to do a proper replacement of those two wards and indeed 2 or 3 other wards. We have an idea around it, and I'm not going to go into detail here. When you're talking tens of millions, there's a bit that can come from the overall trust capital programme. There'll be a bit that can come from things from philanthropy, and the power of the Harefield name will guarantee that we will get, I would say, a substantial contribution from philanthropy. If we can properly set up the 2 academic programmes that I was talking about, that's something that I think would attract investment. I think, given the limitations around that we have around capital spending, we will have to come up with, and that's one nice thing about being part of Guy's and Thomas's, they're used to this sort of problem, thinking of things like sale and lease back, and it's not an ideal thing, because fundamentally you are selling a long-term lease on a piece of property. You're persuading a pension fund, a developer or a big pension fund to build you a new hospital or build you a new facility, and you pay for it over 40 years. Yes, you get the freehold back after 40, 50, 60 years, but you pay a hefty chunk of money for it, and it's not PFI, I do hasten to add, but it is if you like, a burden on the hospital's ongoing P&L. I'm not saying we're going to do it, but I'm saying that we'd have to look into that, because trying to raise the money for a multi-tens of millions, whatever, refurb master plan, we've got to look at every single option we've got. I would hope, though, philanthropy would be a very big chunk of it.
If anybody knows anybody. Anyway, all right. One more? Yeah, go on.
I was really interested to hear about this recruitment process going into secondary education and colleges that you were talking about. Oh, sorry. Maybe I should shut up. Sorry. And I just wanted, because this is the dilemmas that you have about filling in other spaces and finding kind of recruitment where people understand other technical roles. I come from a media industry where this same thing happened, where everybody wanted to be a film director and didn't realise about all the other roles that could be in place in there. And I wondered whether, what kind of qualifications are needed, whether people are aware of the qualifications that are needed, and is this an awareness-raising programme, and also whether any kind of, dare I say, apprenticeships could be applied to something like this.
Almost certainly. We're right at the beginning of it, and again, this is one area where it's been good to be part of Guy's and Thomas's. They have run now for about the past 5 or 6 years similar such programmes with colleges in South London to attract a variety. A lot of it's around nursing, but a lot of it is around these allied health professional technical roles as well. And they haven't done it for long enough to be able to measure and say, if we reach 100 emerging young adults in these three colleges, we will see a feed through of 10 coming through. It's too early to do that, but they do have a fairly robust program around that. And what we were thinking is we need to do something similar for Hillingdon with Harefield, and with Brompton and the boroughs that neighbouring to it down in Chelsea. I think the earlier you can intervene using, as you say, the apprenticeship levy. I'm not an expert on it, but using that in a very a way that's targeted at filling the cohorts where we have difficulty recruiting and retaining. That has to be the way to do it. At the moment, we don't have the data to say, like I said, this is, if you do this much effort, this is the yield we'll get. But part of me just thinks it's an act of, you kind of know it will work. To use a fishing metaphor, it's spreading bread on the water. You know some of it, you'll catch fish, as it were, off the back. So, sorry, we don't have a program. It's just early thinking, but there is a program at Thomas's, Guys and Thomas's, which we know some people have come through from so far.
I mean, something to look forward to, get more information in the future.
If I could just comment on that.
Go
sorry.
on, quick.
Sorry, just looking at other industries as well, because the aviation industry and engineering and car engineering and all this kind of, and whether it's Formula One or whatever, BA do it, Rolls-Royce do it, and this is like proper engineering. So I just wondered if that could be if you look at that as well. Anyway.
Brilliant. Okay, thank you. June, is there anything else you want to say on this subject?
Yeah, I just wanted to know, because sort of took my question now. How are you linking with with the college and education establishment to raise the awareness of the youngsters, let's say the next two generation, in regards to looking at the roles and job prospects in the areas that you have discussed here tonight?
We haven't done it. So at Harefield, we have every year an open day for a number of sixth forms. I can't tell you the number of schools, but there are a number of schools from the borough. And it's a sort of, this is what happens in a hospital, and you might think about a career here. We haven't methodically followed up on it. If I think about more specific things, so cardiac physiologists, who are the people in the cath labs, when you have your heart attack and you get brought to us by Chris and Clinton, they're the guys who operate the fluoroscopy equipment, allow the cardiologist to get the image, and then he or she can put the stent in and so on. Because it's so hard to recruit these physiologists, we've worked very hard with Brunel, and we now have, I think it started 2 months ago, an MSc that we've set up in cardiac physiology. And next time you get Derval to tell you more about that, because she was instrumental in setting that up. And there are not enough of these, if you like, training courses or MScs around the country, and this was, I think, might have been the first or the second of its kind in the country. We need to do more of these, and obviously if we help set it up and we provide some of the faculty, because we're at the local hospital to Brunel, there's a good chance that a fair number of the students coming through will come to us, come and work with us. It's a flavour of what we're doing, but we don't have a comprehensive, well thought through, well resourced, well planned programme yet.
So something to hear more about, so that's very good. Thank you. I'm going to cut you off there, because this has been very interesting, but I'm conscious of time. But thank you very much for coming to speak to us, Piers. So, Lisa, you are certainly not least, but you are definitely last, which is something to celebrate. Can you let us know what Hillingdon Health Watch is interested in at the moment? And yeah, that would be really good. Thank you.
Thank you, Chair. So I've just been sitting here thinking how can I continue the theme of innovation? And I can say we've got a new reporting system and a TikTok account. So there we go.
Does it involve dancing?
It may well involve
Okay,
dancing.
fair enough.
So I assume you mean the TikTok account and not the reporting system, yeah. So this is why I've only got figures from January to May, because trying to triangulate the two just seems like a bit of a headache. So we've received about 161 inquiries and instances of feedback reported by residents from January to May, mostly through our information and signposting service. So that doesn't include the community engagement that we've done, surveys or anything like that. So there's a lot more than that. I suppose the top three themes that we're hearing about are access to phlebotomy services and blood tests at the hospital. But that's mostly because of a slight communication issue where our details are put on all of the letters. So people are contacting us, which is not necessarily a bad thing, because they now know who we are. But we're working with the hospital and particularly the PALS team to make sure people can get their appointments when they need them. You won't be surprised that general practice is high up on the list, particularly with regards to getting appointments, and also with callers experiencing some issues around administration, particularly now that people can request access to the medical records. And the new NHS app. So just some confusion around how to access those services and how to use them. We have seen, in terms of signposting, most of our signposting has been to PALS, and a lot of that, as I said, is due to the phlebotomy appointment issue. And we've also referred quite a few people to POWER for advocacy advice, and I think we've seen a bit of an increase in terms of our referrals to that service. We have been really busy, and you may remember me talking to you last time about how we were looking at running a campaign to understand people's experiences of accessing their GP, and so that is in progress at the moment. I think we've received over 100 responses so far, but we're still working with partners to try and maximise responses and reach out to the community. Also doing some targeted engagement work as well with community groups. I have spent the last 6 months working with CNWL to interview patients in their inpatient units as to their experience of Riverside. So that's been going into 5 of the wards, including the acute wards, and also the rehabilitation centre as well. So we have interviewed around 40 patients, and I've also just recently run a carers focus group and interviewed some carers as well, so to make sure that their feedback is part of the process. There is an improvement plan that's been developed, and we've agreed that we will go back perhaps next year and just monitor progress with that and whether that's made a difference. So the themes we were looking at included the ward environment itself, provision of meals and activities, quality of care, communication with staff, access to information and support, so whether patients understood what their rights were under the Mental Health Act, and that they had a right to an advocate, and also access to visitors. We are, I have mentioned this before, but we were successful in getting a bid to run a campaign for children and young people, improving children and young people's mental health and emotional wellbeing services in the borough. So that's very much underway. We have launched a generic survey that we've now had over 100 responses to, and we're just working on analysing that preliminary information at the moment. But again, doing some more targeted engagement work with children and young people who we know are at higher risk of health inequalities and discrimination. And the purpose is to co-produce some recommendations for improvement to services particularly around what the front door of services looks like, and making sure that children, young people and their families get the right care at the right time, in the right place and in the right way that works for them. We have supported the Hillingdon Hospital Trust and the Harefield Hospital Place inspections this year with our volunteers taking part in those. We have done a lot of community engagement and outreach, so we've been very much involved in planning and delivering the neighbourhood roadshows and some smaller health and wellbeing sessions in targeted communities. We regularly attend the Older People and Disabilities Assemblies and Brunel Engagement Day, and we're working with Brunel at the moment to see how we can work together to progress some research in the community. Social media is going well, and we've regularly seen growth on our platforms. Obviously, it helps when we're running a campaign. And actually a lot of the growth that we've seen came through the work that we did for the London Ambulance Service in reviewing their strategy. So that's good. We've got about 13 active adult volunteers at the moment. We do need some active board members, so please give that some consideration and obviously spread the word because we are attending so many more meetings now than we were, so we really need some help in just having the capacity to be able to do all the work.
Could you send details of that to Nikki so she can send them out to circulate to us? Because we meet lots of people who, I mean, I know a couple of people off the top of my head who might, be useful. Yeah. So if you send details to Nikki, I can definitely forward them on to some interested people potentially.
Thank you so much. That would be really helpful. And we. Next 6 months, our volunteers were very keen to do a review of pharmacy services, particularly with the introductions of Pharmacy First scheme. So we're in the midst of planning that at the moment. And as Patricia mentioned earlier, we've been in talks about perhaps doing some reviews of maternity services and A&E experience as well. So there's a lot in the pipeline, but I would say mental health has probably been our biggest focus and probably will continue to be for the next year.
Thank you. So much work as always is in the health field. First of all, I've an ask of you. At our next meeting, we will be discussing essentially our next year's work programme, so to get some views from you before that meeting about some of the stuff that maybe would be good for us to look at, because obviously, Hillingdon Health Watch picks up some great information about what people care about and what the issues are. So that would be extremely useful. So you don't need to tell me now, but that would be extremely useful before we discuss what we do over the next year. And I wondered if you could say anything more about the accessing GP work that you're doing, because obviously that is a really hot topic at the moment. And obviously a lot of critical press coverage of GP access. I mean, have you got a flavour of how things are in Hillingdon and what the main concerns are?
Yes, so access is a broad term, really. So it means very different things. Obviously, we've already spoken in this meeting about the issues that areas like Heathrow Villages face with regards to provision locally and Harefield residents as well. In other areas, it can. What we're hearing are issues surrounding the digital appointment booking systems with people who perhaps don't have the digital literacy to be able to use them appropriately, or people who would like a face-to-face appointment, which they have a right to have, being told that they have to follow the digital access route first. So those do seem to be the main issues. Not many people will actually contact us directly because they can't get an appointment with their GP. Most of the feedback I've received has been when I have been out and about in the community, discussing health concerns with people, and it's usually when I mention to them about, or ask them, have you made an appointment with your GP? What's worrying is hearing the number of people that have said, no, there's no point, I've given up trying. So that to me is the concern on why I felt very strongly that we needed to do some work on this, because I'm really keen to hear from the people that don't know who we are, wouldn't think to contact us, wouldn't think to raise that as an issue in the first place, and actually where are they going and how are they receiving medical support when they need it. So yeah, so does that, hopefully that answers your question.
That's a good start, and obviously as you do get more research and once you do the report, I think we'd be really interested in maybe something we might look at more in detail. That made me think actually every time you're in a social situation, you say what you do, you probably get lots of people unloading their experiences on you, which is something we get as councillors sometimes quite often anyway. Philip, you had a question.
Just quickly, we've not heard from C&W this evening. We've got a written report. It states that there have been significant improvements in CAMS, waiting times. Is that something that you're broadly in agreement with, based on the feedback you're getting? And just cheekily, one final thing, I see the shops closed in the shopping centre. Do you have an office now, or will you be getting one, or what? Thank you.
Okay, so I'll talk about the shop first. So yes, the shop has closed, and that's due to the changes in pavilions management. We don't currently have an office space, but I am pursuing the possibility of having some office space within the civic centre once the refurbishment's completed. So that's definitely a long-term plan. At the moment, we're working remotely. However, what I would say about that is it's presented a lot more opportunity, I think, for us to be out in the community without the resource needed to manage a shop that's open to the public, which wasn't receiving much footfall anyway. So I think there are some opportunities for us to like I said, to be out in, and talking to communities that actually don't know who we are, to raise our profile, and to encourage and empower people to speak up. So that's the situation with the shop. With regards to CAMS, I haven't received as many inquiries recently about CAMS. I know that with the new triage system in place, that has reduced waiting times to triage. I don't know what the current situation is from triage to treatment, but I do know that CAMS are working more closely with some of the voluntary sector partners, so that when they have triaged a young person, they're able, if it's not suitable for CAMS, then they're able to signpost that family to a different service, to an early intervention service that might be better for that young person. And I have heard feedback from parents that have said that, organisations like P3, for example, have really made a positive difference to that young person, because they can be flexible in the way that they offer their service. I know that doesn't answer your question about waiting times, but hopefully it means that there are more services at the family's disposal, and there's greater awareness around what else is out there. I do know that CAMS have introduced some new services, so there's now an under 5 services, and I know that the mental health and schools teams, I think there's been a second tranche, and hopefully, I'm sure C&W will correct me if I'm wrong, but I know that they've expanded the programme, so there's now more schools with mental health practitioners within them. So I think there have been improvements, and part of the work that I'm doing, which is reviewing services at the moment, will hopefully highlight where there have been some changes and where there have been improvements made, but also perhaps where there are still gaps that need to be addressed.
Thank you. Signal.
It was just, I was just trying to bring a few threads together that have been heard this evening, and I keep coming back to this complex health issues kind of scenario, and I just kind of looking at this GP access, and thinking about this a little bit more, because GPs have, there was a point, have had to increase the amount of residents that they have on the books, which has then had an impact on people accessing appointments, which has then driven the GP services to go digital, because it kind of enables them to see, you can see where that's going. And yet, one of the things that concerns me is the elderly who might need to go and see someone and then do that, I've given up. Women with issues that they might need to go and see and go, I can't get an appointment for 3 months or something like that, or it's like, the next available appointment is on the, 12th of October or something like that, and you need to be seeing it within 48 hours, and you can't do that. So I just think that there's a lot of cogs that kind of form the picture of why we're in this bit of a mess in terms of our GP services, but also therefore the attitudes of the GP services themselves towards their patients, that actually once upon a time it would be, you could go in, there was that care and that empathy that this is a patient, as you were talking about, that they're in need of care, and all of a sudden it's like, well, I can see you digitally, you might not need to see me, but actually there might be something underlying from that headache that is not quite a headache, or that, pain in the left side of their breast, which is not quite the pain in the left side of the breast that they think through a photograph of something. So I just kind of wondered if that's something you've picked up on.
It may be something that does come up through the campaign that we're running at the moment. I think when I've spoken to GPs, I think many of them would agree that they do like to see people face to face, because they can pick up on symptoms that perhaps the person wouldn't have reported via the digital system. So I don't know if there's any data on that. I think the borough, probably the borough director would be able to answer that question. So, it may well be something that comes up through the work that we're doing. And like I said, it's not always, these aren't necessarily the things that people contact us about. It's more as we're out and about and picking up and having those conversations. So I think the more that we're out there and asking those questions, the more perhaps some of these issues might come to light. I couldn't sort of say, yes, that's an issue, or not about, and whether it's to do with the digital platforms, I don't know. I think that's probably something that needs a bit more of a deeper dive.
Thank you. Tony.
Thank you, Chair. Patricia in her submission said about the hub, the sort of eased some of the pressures on A&E for people turning up at A&E and instead of going to a GP and they're going to the hub. You're saying it's still an issue for a lot of people about getting an appointment with GPs. Are people aware of the hubs, or do you think the hubs are working, or have you had any feedback on them at all, or anything like that?
I think the hubs are still relatively new, so it's very difficult to know whether it's made a difference yet or not. There is a plan that through the community roadshows that have been taking place over the last few years, and there's some work being done at the moment to develop a business case for that to be a 3-year programme. That part of that work would be to engage with communities to promote the hubs and promote the use of the hubs, and for residents to understand actually what services are available, how they can access them. And I know that the plan, I think there's already a hub in Ruislip, and the plan obviously is to have one in Uxbridge and one in Hayes as well. So, but those two are very much still in progress as far as I know. So I think it's a bit too early to tell, and I think there's probably still a lot of communication and engagement that needs to happen to promote the hubs.
Great, good. June, go for it.
Just quickly, Chair, this is why Keith Spencer should be here to answer some of these questions, because questions we need answering. In regards to the GP digital connection, there's quite a lot of elderly people who are unable to use digital phones. some of them just have those little phones just for a phone call. And it is very difficult for them to get through to GP services to speak to someone, because when you do, and I've tried, and I will call myself an elderly person because I am over 65, and therefore my expectation is to be able to speak to someone face to face, and that is very difficult for myself and some others in my group that I go around with. They're able to either call and ask, but there's still not that provision for a face-to-face conversation with a GP receptionist. And that's something that, Keith Spencer and the others would, is something we need to drill them on, because the digital thing is fine, but it's not fine for everyone. And, it causes grief to elderly persons and those who are unable to deal with the phone or digital equipment, and it can be harrowing for them. And some of them do turn up to the GP service, because I have been to my GP where a couple of elderly people turn up and say, but I can't do it. That's why I've turned up here to do it. And, it's like you doing the receptionist, you're giving her headache or him headache because, well, this is the system. This is how you have to do it. And that shouldn't be so, because you should be able to turn up to GP service. And if you cannot access those digital systems, the receptionist or whoever there to provide the service should be able to do that without they having to go through that stress. And it is not an easy task, because I've been through it. Patches. Take that, for instance. You said, go on Patches, log in on Patches, do this. Then you have to write exactly what it is. Why should I be writing what it is? I want to see my GP because I have a problem, but I got to write. When you're in a state like that, you can't write anything to say to the GP, this is what it is. And I just said, I need urgent care. And then they came back and said, well, what care it is? Now, if me, who can deal with that, what about someone who cannot deal with that? So, and hence the problem we still have in the A&E, because people are turning up because they're not being able to access the GP services. It's just my beef. It's a rant I have on that.
Thank you.
You're not the only one who has that rant. And I think two things. I think obviously the GP access work you're doing is super important, and we'll be super interested to find out what you discover.
Thank
I think
you.
it's something we might look into more deeply. We'll talk about that in a second. But Lisa, any
just
views on what June said?
Just to come back on that point, because I absolutely agree with you, June, on that. I think, the NHS is very clear that there's patient choice around how they would like to how patients want a GP appointment. And our concern is that choice is not being adhered to by a lot of the practices. So that's why I think this work that we're doing is really important, and it's timely, particularly when there's now a sort of primary care strategy, the development of the hubs. So I think it's really important that whilst those hubs are being developed, and they should, or the purpose of them is to ease some of this burden, but obviously make access easier for patients, I think it's important that the feedback that we get from this survey actually is campaigning for, or influences how those hubs work. So absolutely take your point. Absolutely agree with you. And I would also say that it's not just older people that find accessing the GPs challenging. It's also people with cost of living at the moment. People can't afford to wait on the phone for 3/4 of an hour, and they may not even be able to afford access to the internet. So there's all those types of issues to contend with as well.
I've got lots of views on this, but I'm going to save them for another meeting because I want to get home to watch 10 o'clock news tonight, because apparently something happened in the news that might be people telling me it'd be of interest to me. I don't know what it is, but I think we will close this item now. So thank you everyone who's here, who's come and spoke to us. It's always really interesting. It always goes on for a lot longer than I think, because there's always so much to talk about. But thank you, your attendance is really appreciated. So you may leave now. We have one more thing to discuss, I think, only, don't we? Two. Okay, two more things to discuss, and then we can do off record later. This is on record. We're public, so no swearing, June. No. It is something that people are very passionate about. So, okay. Does anybody have anything to say about the Cabinet Forward Plan? No? Excellent. I'll move on to the next item, which I think we've got a little bit to say about, not much hopefully at this moment in time. So, which is the work programme. There's two things I want to talk about. The first thing is myself and Cecil had a presentation from Sandra, who's the head of social care, a week ago, I think, about where they're at with the CQC process and all that sort of stuff. So in very broad terms, 3 boroughs were announced that they were going to be investigated by the CQC. Westminster, Ealing and Hillingdon. Investigators are in Westminster at the moment. In terms of the sort of preparatory work, more preparatory work is being done with Hillingdon than with Ealing. For example, some of our third sector partners have been spoken to and more information has been asked to. So the sense we have is that Hillingdon will be looked at next, and the view was possibly early July. I don't know if an election affects that or not. Anyway, and after the inspections happened, a report will be published probably within a couple of months. Okay, so my view was that the getting Sandra and the cabinet member in charge, Jane Palmer, to a meeting would be useful to get them to the meeting after the report's published, which I think, looking at our programme, would be November or October. And I know it says no meeting in October, but I'll come back to that in a second. So that was my view, because I think after the report's published would be a good time to speak to them. Philip?
I don't disagree, but I do think it's desirable that as a committee we should be cited on, or at least have some awareness of, LBH's own assessment of where we sit on our improvement journey. I'm not aware that we've seen that, and I think as the committee responsible for scrutinising that service, we should have access to it or some information about it. Can I just make that point? Will we get that at some point?
So myself and Cecil have asked for that, and we're going to be given that. The promise was that we'd get an abridged version, because apparently there's a lot of extra data such as that wouldn't be necessary, but we are going to get a version, and we will share that with committee members when we get it. So hopefully soon we'll get it. But yeah, no, point taken. And the second thing I wanted to float, which is I want everyone's contribution, including Nikki's contribution on this. Obviously, our next meeting is meant to be on the 19th of June. We've had the announcement of the election, which is going to make us all busy in certain ways. And I was going to use the 19th of June really as a main sort of talking about our work programme and what we wanted to do. Two aspects to that. One is obviously our in-depth review. And for that, I was thinking of concentrating on the social care issue, because we did our last one on an external service provider, and that would be good. But secondly, I know last year when we did or last term, shall I say, when we did the Harefield and Heathrow Villages sort of one meeting investigation, I think committee members found that useful to deep dive. And so I want us to come up with maybe 3 possible ideas where we could deep dive into a single issue as well. I'm sure GPs would be one of them. So I'm not asking for ideas now, but something to think about before our next meeting. Now, I wonder, I don't know if this has just come off the top of my head after the Prime Minister's announcement today, is if we cancel the June meeting, but then put in a meeting for October, because at the moment we have no meeting booked in October. So we don't lose a meeting, we just move it to October. That will give us, and in July we'll have a meeting where we move some of the things across, and then we do the sort of discussing the topic selection. So any views on that? Firstly, Nikki, do you think that's practical from a governance point of view?
Can I use your mic?
Yeah.
Thank you. From a absolutely fine in terms of the way the committee works. There's no reason why we can't, and actually it would be beneficial in terms of the democratic side that I work on, for me.
And that is important to us, because you do a lot of work for us. What do other people think?
I think it's important that we do, because all of us is involved with our constituents, or should I say with our party in regards to campaigning, and that will be very, very demanding on us, campaigning as well as coming to sit down in a committee and focus on functions. So I would agree with that.
And sometimes people don't like coming and speaking to us during election periods. I've had that in the past as well. Yes, we'll still see each other in June, won't we? But we'll be probably on other sides of the road when we're walking up and down. I mean, so are we happy with that idea? So June's, in a sense, we cancel June's meeting, but then we put in an October meeting, so we don't have any less meetings. But and what I'll do is after this meeting, I'll send out an email to everyone on the committee saying, please come up with ideas, because I want. So, the July meeting, we definitely can come up with an idea for a single topic, in-depth review, and free, single meeting reviews. So good. Okay. Is everybody happy to end the meeting? Am I allowed to end? Oh, sorry, yes. Sorry, that microphone on, please.
Sorry, could you just say that again? So, not about the fact that we're cancelling June's meeting, but when did you want us to discuss that in-depth topic review? Sorry.
So what I want is in July for us to discuss the topic selection, and by the end of July's meeting, I want us to have one proposal for an in-depth review and 3 proposals for a single meeting review. So, for example, it would be something like, I don't know, the in-depth review could be something around social care and how we do early intervention. This is just an example that maybe come from conversations I've had, but we can adapt that. And then the individual meeting reviews could be something like GP access or whatever. But in order for us to do that, I think I will send out an email to committee members and ask for ideas to be shared before then, because then Nikki can work on some stuff, and that means that we can then leave the July meeting having that nailed down, which means then the rest of our work programme we can fill it in with stuff, which is good. So that was it really. Yeah, great. Excellent. Okay. Are we all happy? Fantastic. Shall we end the meeting? Thank you, everyone. It's been a long one, but it's been a good one. Thank you, everyone.